विकास फोन करके पूछना होगा कोरोना वाले को, मेरा वीडियो क्यों ऑफ कर दिया है।
उसमें नहीं है पैन कार्ड, किसको चाहिए?
Good evening, all respected faculties. I invite you all for the Happy Learning Masterclass webinar series 103rd edition in association with Katihar, Patna, Saharsa and Sitamarhi OBGY Society. Topic for the today's webinar is amniotic fluid, the holy water. Convener for the today's webinar is Dr. Sneha Bhuyer. She is Chairperson Breast Committee FOXY, and Dr. Vinita Singh. She is President Patna OBGYN Society. Coordinators for the today's webinar is Dr. B. Kalpana, Secretary Madurai OBGYN Society, and Dr. Jyoti Banglowala, Past Secretary Indore OBGYN Society. Master of the ceremony for the today's event is Dr. Supriya Jaiswal, Secretary Patna OBGYN Society, and Dr. Apurva Kumar Datta, National Coordinator Medical Committee. I welcome you all, respected faculty, and I invite you all to light the lamp.
वीडियो क्यों नहीं ऑफ किया हुआ है? मेरा ऑफ किया हुआ।
Thank you, respected faculties. I invite Dr. Vinita Singh, ma'am, for further proceeding.
Very good evening, respected dignitaries, Padma Shri Dr. Shanti Roy, madam, as chief guest, and as guest of honor, Dr. Manjugita Mishra, madam, and Dr. Pramila Modi, madam, and all president and secretaries of different societies as Patna Obs and Gynae Society, Katihar Society, and Saharsa Society. A very good evening to all of you. I take privilege to introduce Guru of all legal issues related to Obs and Gynae, Dr. C. Patel, sir, who is known for his dynamism, enthusiasm, spreading his knowledge at a grassroots level through his Happy Learning Masterclasses webinar, which is unique in its own way because every time there is something different topic has been chosen and all topic is discussed in details along with legal issues also. So I invite you, sir, for your welcome address.
Thank you, Dr. Vinita Singh, madam. It gives me immense pleasure to welcome you all to this 103rd episode of our Happy Learning Masterclass web series. And today joining societies Katihar, Patna, Saharsa and Sitamarhi. And we are going to discuss amniotic fluid, the holy water. I welcome Dr. Padma Shri, Dr. Shanti Roy, madam, who have kindly consented to be chief guest to bless us. Of course, Shanti Roy, madam, is always with me in any of my academic activity. So welcome, Shanti, madam, for your kind gesture and to be here to bless us. I also welcome Dr. Manjugita Mishra, madam, and Pramila Modi, madam. They both have also kindly consented to be guest of honor to bless us. They both are also with me in any of my academic activity. So welcome, Manju, madam, and Pramila, madam. I also welcome two learned speakers, Dr. Rita Kumari from Patna. She is going to discuss very important topic of amniotic fluid embolism. Of course, rare entity, but if at all it happens, then it becomes a very difficult one to manage. I also welcome Dr. Rakhi Agarwal, madam. She is going to discuss amniotic fluid and ultrasound. I also welcome two learned moderators who are going to moderate very interesting panel about troubleshooting in amniotic fluid abnormalities. Dr. Jyoti Malhotra madam and Dr. Monica Anand madam, both from Patna. I also welcome two learned expert panelists having their expert comments in panel. Dr. Sneha Buyar, she is also convener of this series also, and Dr. Rekha Rajendra Kumar from Bengaluru, she is Vice President of Bengaluru. I also welcome all the learned panelists. Dr. Ranjana Jha madam from Katihar, she is Secretary of Katihar. Dr. Lata Gupta madam, again from Sitamarhi, she is also Secretary of Sitamarhi. Dr. Charu Modi from Patna. Dr. Shraddha Chakariyar madam from Patna.
Hello.
Dr. Vinita Singh madam and Dr. Sangam Jha madam from Patna. I also welcome all the learned chairperson who have kindly consented to chair respective session. Dr. Supriya Jaiswal, Secretary of Patna, Dr. Lakshmi Sen madam, President of Katihar, Dr. Sipra Singh madam from Patna, Dr. Pragya Mishra, past chairperson, Genetic and Fetal Medicine from Patna, Dr. Nibha Mohan madam, Joint Secretary of Patna, Dr. Vinita Singh madam from Patna, President madam, and Kalyani Singh madam, President of Saharsa. I also welcome B. Kalpana from Madurai. She is coordinator in our series since long. And of course, Jyoti Banglowala, Vice President of Indore Society. I also welcome two learned Master of Ceremony, Dr. Apurva Datta from Dhanbad and Dr. Supriya Jaiswal, our own from Patna. So I take opportunity to thank first Dr. Vinita Singh madam and Dr. Supriya Jaiswal madam for all the help they have extended me for this particular webinar. In the era of COVID-19, where physical meetings were not possible, we four friends started this Happy Learning Masterclass web series to meet all the Foxian friends on virtual ground, to say hello, to exchange our knowledge for any focused topic. And ultimate goal was to be helpful to our patient and to check maternal and infant mortality, because it is a direct concern as an obstetrician, because by 2030, government has given us target, and WHO of course also, that maternal mortality should be in a double figure, it should be by 70, and infant mortality should be 12. Of course, there are few states in southern India, they were already nearby 30 or 32. At the same time, there are few states in northern India, if I can quote the state of Assam, having maternal mortality of 200. So, if we go join hand, government, NGOs, federation like Foxy, IMA, and all obstetrician friends, and particularly who are working in very remote India, and then only we can check this maternal mortality and infant mortality. So with this aim to discuss focus topic, and at the same time, when we think about safety of patient, but at the same time, we have to think safety of our obstetrician friend also. So we also discuss one legal topic also related to that particular topic. And today only, I am also going to discuss legal issues in amniotic fluid abnormality, whether it is polyhydramnios, whether it is oligohydramnios, or whether it is amniotic fluid embolism. So with this aim, we started this series, and I am now happy to announce that now we are a happy family of Happy Learning Masterclass, 7,000 plus members as far as this Happy Learning Masterclass is concerned. So welcoming you all the societies who have joined today's webinar, Katihar, Patna, Saharsa, Sitamarhi, all the delegates and all the president and secretary of respective society, welcoming you all. And thank you again, Dr. Vinita Singh and Supriya, for all the help. Thank you very much. And over to you, Vinita Singh, for further proceeding.
Thank you, sir, for your such a wonderful words. Now, I really am feeling proud, privileged for inviting a national but international figure, Padma Shri Dr. Shanti Roy, madam. She is today's chief guest, and we all know that she is teacher of teacher. She was president POGS, ex-professor and head Obstetrician Department, PMCH, and everyone knows her. She is just like mother figure to us. So we all know that regarding her CV, she is consultant obstetrician and gynecologist at Patna. She was ex-professor and head, PMCH Patna, center head of ICOG training, reproductive medicine, Shivam Hospital and Research Institute Private Limited. She is chairperson, ISAR Patna branch, fellow guide, Narchi, ex-inspector, ex-examiner, and ex-advisor, National Board of Examinations, New Delhi. Her organizational positions: she is ex-president Bihar Obstetrician Society, as I've already said. She was in 1995 to 96, ex-member governing council of ICOG, organizing chairperson 57th AICOG 2014 Patna, which can be remembered by everyone. Her books and articles, she has edited many books on Obs and Gynae in Hindi, Garb Jeevan Prasav Gyan, Stri Rog Gyan, contributed chapters in many other books related to Obs and Gynae, contributed many research articles in various journals in India, and participated in many conferences and seminars in India and abroad. As she has received many awards, awarded Padma Shri in the year 2020 by Government of India, Lifetime Achievement Award by Foxy OGSH TAIOG 2019, IMA Bihar, Bihar Obstetrics and Gynecological Society Bihar, Dainik Jagran 2015, the Icons of Bihar Award in 2018 Outlook, Icons of Health Award in 2020 by the Times of India 2020, Doctors Pride Award 2019 for Excellence and by Dainik Bhaskar 2019, and her field of special interest is autism, public awareness for healthy living, and cervical cancer. So over to you, madam, for your blessings, words of blessings.
Thank you so much, Vinita, Dr. Vinita, for such nice introduction. Thank you so much. And I am really obliged and thankful to Dr. M.C. Patel, who requested me to be the chief guest of today's very important function and the very important webinar on Lycopodium. Actually speaking, I sincerely appreciate and admire Dr. M.C. Patel for all his attempts, for his dedication, for his zeal to do something and something. Always he is trying to do something to make the people aware, to make the doctors aware, and to do something for the society, for the health of women. I really, not only me, but my whole society, Patna Obstetrics and Gynecological Society, always appreciates all your attempts, and we are always with you. Whatever you do, we are going to cooperate with you. I know you are doing many things in Ahmedabad, and I feel many times I am overwhelmed by knowing all those things, and I wish we could also do such things in Patna. So thank you very much for inviting me to be the chief guest. The subject you have chosen today is very important. Lycopodium, all the practicing obstetricians and gynecologists, they are aware of the importance of Lycopodium. Lycopodium, sometimes it is very large in amount, it is very small in amount. Sometimes it is normal amount, and it is very mischievous because today it is normal. The ultrasound shows Lycopodium is of normal volume, and after 1 week it shows that it is diminished a lot. Only scanty Lycopodium is present. So there is always a dilemma with the Lycopodium, and we all know that the Lycopodium is an indirect evidence for fetal well-being. The obstetricians depend upon Lycopodium for taking care of the fetus. So it is a very well-chosen subject. And I think the term holy water, I want to say a few words about holy water. Lycopodium, it is holy water, no doubt, because it is in the mother's womb, and it is holy actually because it is mother's, and the mother gives nutrition to the baby through it. But it is full of fetal urine, fetal feces, fetal sweats, and many times medicines and many dirty things also. So whether it is holy or not, we have to decide it. Nobody wants to touch it, or nobody wants to touch it with bare hands. We only touch it by gloves hands. We never want to take bath with it. We can't take it. So how far it is correct to say that it is holy, I don't know. But Dr. Patel must have thought something, and that's why he has given the name holy water. So thank you very much for inviting me. And I hand over the slide to
Thank you.
organizers.
Thank you very much, Santi Roy madam, for your kind words. You are always with us for any of our academic activities. So thank you very much for sparing time.
Thank you, madam, for your words of blessings. Now over to Dr. Supriya Jaiswal, my dynamic secretary, for further proceedings.
Thank you so much, Vinita Di. First of all, I would thank Dr. M.C. Patel, sir, the program director of this program, Happy Learning. Sir, we have been watching your program since long, and it really is Happy Learning. So thank you very much for giving me the scientific and also the MOC part. Thank you, sir. So to introduce another one, another legendary figure, Dr. Manju Geeta Mishra, madam, who is the guest of honor of today's program. May I have the CV, Mr. Abhishek? So madam is the very dynamic personality of Patna OBGY Society, a very senior and respectable madam. She is the past president IMA Bihar chapter. She'd been the vice president of All India Women's Doctors Wing, at present CWC member, President ISOPAF from 2014-16. At present, madam is consultant at MGM Hospital and Research Center, chairperson Medical Education Committee, FOXY, since in 2007 to 9. She has delivered many orations, guest lectures in state, national, and international conferences. She has contributed chapters in FOXY publication and edited book, Critical Care in Obstetrics, first and second edition, Treatment and Prognosis in Obstetrics and Gynecology. More than 70 publications in various national and international journals to her credit. She has been an appointed inspector by MCI and National Board of for Recognition of DGO, MD, and DNB course in various colleges and institutes. Madam had been the examiner of undergraduate, postgraduate, DNB students. She had special interest in high-risk pregnancy and adolescent gynecology and emergency obstetrics. Madam had been the past Senior Vice President ISOPA, past President BOGS, past Secretary General ISOPA, past President Association of OBGYs, AOGS BJ. She had been recipient of many prestigious awards like Kanak Goyal Award, CL Javeri Family Planning Award, Dr. B.C. Roy National Award, and R.K. Minda Community Service Award. Madam has organized various seminars, workshop conferences, organized more than 100 rural health camps in different rural areas of Bihar. She has promoted OCP and AIDS awareness in different parts of Bihar at different times. Organized All India IMA conference held at Patna, organizing secretary of AICOG 2014. Then she had ad hoc committee member, Red Cross Society, where she had served tirelessly for so many years. Then Lifetime Achievement Award was given to her by POX in 2015. Then Jagran Health Excellence Award in 2015, Lifetime Achievement Award by NARCHI in September 2016. And Madam is a very loving person. She's a very helpful person. And Madam, with these words, I request you to kindly share your pearls of wisdom.
Thank you, Dr. Supriya, for your kind words. Respected Dr. M.C. Patel, first of all, I congratulate you, Dr. M.C. Patel, and thank you for taking such keen interest in organizing this webinar and taking Happy Learning master classes. And you have taken this class all through the COVID era, and all the members of all the societies are benefited by this. So the respected chief guest of this occasion, Dr. Padma Shri Dr. Shanti Rai, guest of honor Dr. Pramila Modi, speaker, convener Dr. Vinita Singh, Dr. Supriya Jaiswal, and speaker Dr. Rita Kumari Jha, and Dr. Rakhi Agarwal, and all the panelists who are taking part in the panel discussion. So I congratulate and thank all the participants who are taking part in this seminar, this webinar. First of all, as Professor Shanti Rai has told, that the amniotic fluid is whether it is the holy water, but I think it is really holy water, because it is free from any impurity, surrounds the growing fetus in the womb, and protects the fetus from outside injury and temperature changes. And it also allows the freedom of movement and permits the musculoskeletal development of the fetus. So actually, I thank you, Dr. MC Patel, for choosing taking this nomenclature, that amniotic fluid is holy water. The second topic is amniotic fluid embolism. But as we all know, that amniotic fluid embolism is a very rare condition. But once it occurs, it is a serious condition. And most of the time, prognosis is very poor and we lose the patient. And most of the time, the women do not survive after this. So again, this amniotic fluid embolism is a very serious condition. And once it occurs, we become very much desperate until all the diagnoses are made on all the persons assemble. In most of the time, we lose the patients. Third topic is the amniotic fluid and ultrasound. Ultrasound is very important because with ultrasound, we assess the Leica pockets. And by assessing the Leica pockets, we decide the prognosis of the fetus. So all the subjects which has been chosen are very important. And the panel discussion, it is also very good, very important. And I thank all the speakers who are taking part in this webinar. So once again, I thank Dr. MC Patel for giving me this opportunity to be the guest of honor of this important session. Thank you, Dr. MC Patel. Thank you.
Thank you. Thank you very much, madam. You are always with us with smiling face always. Whenever I call, you are always there to bless us and to encourage us. Thank you, madam, for sparing time. Yes,
Thank you,
Supriya.
madam. Thank you, madam, for all your nice words and pearls of wisdom that we could learn from you certain new things. Thank you, madam, for your wonderful talk. So now over to we have another senior member, a very senior member, past president of Patna OBGY Society, as guest of honor today, Dr. Pramila Modi, madam. She is the consultant of OBGY Modi Nursing Home, Patna. She has been the vice chairperson of 57th AICOG 2014 at Patna, scientific chair of this very prestigious conference at Patna, and she has been the past president, Patna OBGY Society, ISOPAP past contributor and executive member. Madam had been the past chairperson in Akhil Bharatiya Marwari Sammelan. She has many publications to her credit, almost 50 in both national and international journals. She had contributed 8 chapters in various books of Foxy and others, prepared several informative booklets in Hindi and English regarding pregnancy care, safe motherhood, contraception, nutrition, and menopause. Madam, these booklets were really very useful for the general people. So Madam had also been recipient of several awards and awards like Ethicon, Traveling Fellowship Foxy in 1977 for higher training in OBGYN, Dr. Jagdishwar Mishra Award in 2015, Lifetime Achievement Award by POGS in 2016. Madam holds a special interest in public awareness in safe motherhood, contraception, midlife, and geriatric gynecology. So, Madam, we always follow many things when we have any trouble. Madam, we take her advice. Madam is a very, very helpful person. With these words, Madam, I request you to kindly tell few words of wisdom. Over to you, madam.
Thank you, Supriya. Very nice to see the whole galaxy of doctors who are waiting for so many talks. I'll be a little short. Respected Dr. M.C. Patel, Program Director of Happy Learning Masterclasses Webinar Series, Padma Shri Dr. Shanti Roy, who is the chief guest of today's program, Dr. Manju Gita Mishra, guest of honor for today, Dr. Rekha Rajendra, who is the Vice President of Bangalore OB/GYN Society, all the presidents, secretaries, and members of OB/GYN societies from Patna, especially. Is it audible?
Yes, yes.
Yes, madam.
Fully audible.
Okay, I'm thankful to Vinita and Supriya. They were very keen on that we should be on time. आइएगा मैडम, आते कैसे नहीं, अगर MC पटेल बुलाएं तो हम लोग को तो आना ही आना है. So the various societies are Patna, Katihar, Saharsa, Sitamarhi, etc. And esteemed speakers, chairpersons, moderators, panelists, experts of today like Sneha Bhuar, and viewers of today's masterclass that we are going to have. A very good evening to one and all. At the very outset, I thank Dr. M.C. Patel for inviting me as guest of honor. I thank Dr. Rekha, as I said, and also Kalpana. She just rang up 1 hour before the conference. This is the way we should also learn to work. Reminding is very important, I think. Now, I must congratulate Dr. Patel for his mission of carrying out the masterclass program involving several societies at a time of obstetrics and gynecological societies. I'm extremely happy to know that this is the 103rd edition. Oh my God, really? One webinar or one function takes so much brain, time, and your whole attention. 103rd. I really congratulate you, sir. There's a lot of things that we have to learn from you. I express my good wishes for the success of the scientific event, and lots of congrats once again to Dr. Patel for choosing this wonderful topic. I was much fascinated by this topic, actually. There was a little bit of controversy, holy or not holy. For me, anything which is made by the Prakriti or God should be holy. There is something. समुद्र में गोता लगाते हैं मोती चुनने के लिए, तो ये भी एक समुद्र मानिए, इसके अंदर भी बहुत सी मोतियां छुपी हुई है. And definitely one day, we all may not be here, but some people will find out that particular pearl from that ocean. And at the end, I would like to say that such masterclasses, the programs are very beneficial, and I think that is the best way of spreading knowledge and also a platform for us to come together and discuss from each other. Thank you very much.
Thank you very much, Pramila madam. As the word holy, because in Ayurveda it is written as a Garbhajal.
Dharmajal.
हाँ, गर्भजल. और एक दूसरा शब्द भी आयुर्वेद में इस्तेमाल किया गया है. इस हिसाब से हमने होली वाटर शब्द लिया था.
Sir, it will be proved as holy water one day.
अमृत जल भी शब्द एक है इसके लिए, क्योंकि it is very much necessary for fetus. If you can imagine, if there is no amniotic fluid, then what happens? So with this, we had taken this holy word. But anyway, thank you very much, Pramila madam, for this time and to bless us. Yes, over to you, Supriya.
Thank you, madam. Thank you for your pearls of wisdom and all those things what you spoke just now. Thank you very much, madam. So now over to Dr. Vinita Di. But Dr. Kalpana will be taking over the next session.
With the blessings of our respected seniors of this wonderful program, 103rd episode of Happy Learning series organized by M.C. Patel sir with his tireless work. over the past few years. We, with great efforts from Vinita ma'am and Dr. Supriya for this wonderful webinar. Moving on to the academic session, it's my pleasure and privilege to welcome our chairpersons for this session. Dr. Supriya Jaiswal is the secretary of Patna Huji Society and chief consultant in SM Hospital, Patna, and also attached to Government Hospital, communicator of Central ISOPAR, East Zone Coordinator of Adolescent Committee. She has been elected as a committee chairperson of Adolescent Health Committee FOGSI, member Adolescent Health Committee FOGSI previously, EC member of ISAR Bihar chapter, IAG Patna chapter, and trained in colposcopy, also awarded various awards, best paper awards in various conferences, and she has organized various conferences, Boxcon, ISOPAR, ISPAT, and National Youth Conference. And welcome, ma'am. Our next chairperson is Lakshmi Sen, ma'am, who is the president of Katika Society, and she has got almost 42 years of experience in the field of obstetrics and gynecology, and she was in government service for the past 36 years and member of various organizations. Welcome, ma'am. Over to you, chairpersons.
Thank you, Dr. Kalpana, for introducing me. Thank you. And so now the first speaker is Dr. Rita Kumari Jha, madam. She is Associate Professor, WIMS, Pavapuri. She is President, ISOPAR Patna chapter. She had been in 2019 to 21, Executive Member, ISOPAR 2022, then Executive Member of POGS Patna 21-22, Chairperson Quiz Committee POGS, Life Member FOGSI, ISOPAR, IMS, IMA, SOFSI. And she has been working committee member of Patna Menopause Society. She's been the master trainer, IPAS and PPIUCD, published many articles in national and state journals, contributed chapters in books of FOGSI. And overall, madam is very hardworking and a very wonderful person. So with these words, over to you, Dr. Rita Di, for your talk.
Thank you. Thank you very much. Very good evening to all of you, all my seniors, colleagues, and friends. First of all, my sincere thanks to the organizing team of today's CME, especially Dr. MC Patel and Dr. Vinita Singh and Dr. Supriya Jaiswal for giving me this opportunity to talk before you in this wonderful CME. And my topic is amniotic fluid embolism. As Dr. MGM madam has introduced the topic, it is though it is rare, but it is very fatal and very serious condition. And now I am going to share my screen. इससे करिए
एक बार चेक कर लेना तुम लोग, ऐसा नहीं हो कि हमसे छूट जाए।
You are logging from 2 devices. Just mute one device. Rita ma'am, you are logging from 2 devices.
Yes, I'm just
Otherwise, it will create echo.
Yes, इसमें कैसे शेयर स्क्रीन कैसे वो पहले उसको खोलिए ना
Ma'am, are you facing any difficulties in sharing the screen?
yes
Just on the bottom or top, there will be a green button, share screen.
share screen, and then I want to do with my mail. In mail, it's is there.
So if it is in the mail, just download that presentation first, ma'am.
It is already downloaded.
हाँ तो open your download folder, ma'am.
कैसे होगा?
Ma'am, open your download folder. Open that presentation, particular presentation. Then come back to your this Zoom screen.
Document में है. कैसे होगा? I want to send you mail. Then कैसे होगा? नहीं हटा मैं डाउनलोड किया. ये तो मेरे मेल पर है.
Ma'am, I am sharing my WhatsApp number as well as my mail ID.
If we have any technical difficulty, can we move on to the second session so that the PPT will be ready by the time we can come back to the first session? Is it okay, ma'am?
Error is showing.
Yes, we can proceed accordingly. No issue.
I'm sending you my PPT on WhatsApp.
Yes, ma'am. I have sent both the things.
Kalpana and Supriya, before it gets ready, we may switch over to second lecture.
Yes, sir. Yes, sir.
Yes.
Abhishek, you just take the PPT and get ready with that.
Yes.
Move on to the second session.
Okay.
My PPT on 6th October Happy Learning.
Okay, ma'am. I am downloading it and keep it ready.
Abhishek, you just call ma'am and talk to her and get it.
Now you can share
now and we'll move on to the next.
You can share now. WhatsApp, but I have already sent it. I have.
Ma'am, just a second. The presentation is ready. I am sharing it. Just in a second.
Okay. So did Dr. Jyoti Banglowala did she log in? Dr. Kalpana?
Jyoti is not there actually.
Okay. Hello, Kalpana.
Hello. Presentation is ready.
Hello, Kalpana.
Rita, ma'am. Rita, ma'am, the presentation is ready on the screen.
हो गया है मैडम
Rita, ma'am, please log out from one devices. You have login from two devices and it will create echo.
अच्छा yes.
हाँ तो उसका तो दवाई पड़ ही रहा है यूट्यूब वगैरह.
Abhishek, are you sharing the screen?
Yes, ma'am. I have already shared the screen. The presentation is on the screen now, ma'am.
Ma'am, you can talk otherwise if you are ready with this. Abhishek will be sharing your slides.
वो सुन ही नहीं रही है.
I think she is logged out, I think. We can't see her.
Just a minute, I am checking. Ma'am has not logged in yet, ma'am. She has logged out.
Yeah, that's what I get. Now she can.
Joining?
Yeah, she is joining.
Can you share my presentation now?
Yes, ma'am. Yes, ma'am. Yes, ma'am. So hope it is visible, ma'am.
Yes,
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 yes.
yes.
Yeah.
Yes,
And I am audible?
Yes, ma'am.
Yes.
Yes. My topic is on amniotic fluid embolism. Next. Amniotic fluid embolism is a life-threatening obstetric emergency in which amniotic fluid, hair, or other debris enter the mother's bloodstream through a breach in the barrier between maternal vasculatures and amniotic fluid, thus initiating a complex series of pathophysiological changes leading to cardiorespiratory collapse. Next. Incidence. The condition is so rare that most of us don't encounter it in our professional career. It ranges from 1 in 8,000 to 1 in 80,000 pregnancies. And this variability can be attributed to the inaccuracies in reporting the cause of maternal death, differences in clinical presentation, and the difficulty in confirming the diagnosis in survivors. Regarding historical aspects, it was first described in 1926, but the real significance as a killer disease was recognized in 1941 by Steiner and Lushberg when they published autopsy reports of 8 pregnant women who died of sudden shock during labor, and they believed that AFP was the cause of death in them. Next. There are several risk factors as enumerated in this slide. Maternal age above 35 years, multiparity, strong uterine contractions and rapid labor, abdominal trauma, cesarean section, forceps or vacuum delivery, polyhydramnias, tears into the uterus, cervix and other large pelvic veins, premature placental separation and placental abruption, fetal distress, intrauterine fetal demise, medical induction of labor, which nearly doubles the risk of AFP, and eclampsia. Next one. Etiopathogenesis is still yet poorly understood. It is fortunate that infused amniotic fluid is generally innocuous in most of the cases. Only in some, it triggers a series of pathophysiological changes resulting in abnormal activation of pro-inflammatory mediator systems similar to systemic inflammatory response syndrome. An anaphylactoid reaction with complement activation has been postulated because serum levels of tryptase and histamine has been seen to be elevated in these cases. Next one. And the whole process can be explained in 3 phases. The initial phase consists of pulmonary and systemic hypertension, leading to profound oxygen desaturation, and this is the cause of neurological injury in most of the survivors. About 40% of the initial survivors will pass into second phase, which consists of decreased systemic vascular resistance and diminished cardiac output. And women who survive beyond these 2 phases develop conjunctive coagulopathy and lung and brain injury. Next one. And the whole pathophysiology has been described in this chart. And in the first phase, there is acute right ventricular failure leading to hemodynamic collapse, leading to left ventricular failure with cardiogenic pulmonary edema and systemic hypotension. And in the last phase, there is DIC leading to hemorrhage, contributing to hemodynamic instability and death. Next one. Regarding clinical features, it usually occurs during labor and first few hours postpartum, but has been recorded during abortion and abdominal trauma also. Classically, it has been characterized by abrupt onset of hypotension, hypoxia, and severe conjunctive coagulopathy, though there are individual variations in clinical manifestation. Typically, a woman in late stages of labor becomes acutely dyspneic, cyanotic, and develops severe hypotension. Next one. Later, she may develop seizure and massive DIC-associated hemorrhage leading to cardiac arrest and death. Approximately 50% of patients don't survive the initial cardiopulmonary injury, but of those who do, 40 to 50% develop coagulopathy and hemorrhage up to 4 hours later. There may be a prodromal phase in which the patient may be restless and exhibit an altered mental state. Atypical presentations may be there in some of the cases. Next one. Diagnosis. The diagnosis is essentially a clinical one and one of exclusion. It should be suspected in any patient with a sudden collapse, either during labor or immediately after. The confirmation is done by autopsy. The post-mortem diagnosis is made by demonstration of amniotic fluid debris in the pulmonary vasculatures, and the same may be present in the blood vessels of the uterus, including cervix. Next one. For other diagnostic methods, few other diagnostic methods are also described in the literature, like raised maternal plasma gene coproporphyrin level, which is a component of meconium, and chest radiograph. Findings, though findings are non-specific, but evidence of pulmonary edema may be observed. The other conditions that need to be differentiated are thromboembolic or air embolism, septic shock, anaphylaxis, and myocardial infarction. Next one. Prognosis. Maternal mortality rate have fortunately decreased to less than 30% in some recently reported studies. But besides mortality, there is high incidence of neurological impairment in those who survive. The analysis of National Registry reveals that 70% of cases occur during labor, and DIC is present in up to 80% of the cases. Perinatal outcome is also very poor and is inversely related to the maternal cardiac arrest to delivery interval. Even so, neonatal survival rate is around 70% in some of the cases, but unfortunately, up to half of survivors suffer residual neurological impairment. Next, management. Management is very crucial. Once a presumptive diagnosis is made, supportive measures should be implemented promptly. Speed is the essence which can make the difference between life and death in an acute case. Resuscitation of the mother is the first priority by administration of oxygen by any means available at concentration of 100%. Airway must be secured through endotracheal intubation. And the goal of oxygen therapy is to maintain arterial PaO2 higher than 80 millimeter of mercury and arterial oxygen saturation at 90% or higher. Cardiac output and blood pressure must be maintained. Volume replacement with isotonic crystalloid solution is a first-line therapy. CVP monitoring should be done to avoid overhydration, as these patients are prone to pulmonary edema. Pressure agents are given to maintain blood pressure and inotropes to increase cardiac contractility. Steroids are used in high doses as process is thought to be immune mediated. Next one. Next. Coagulopathy is treated with fresh frozen plasma, platelets, packed RBCs, and cryoprecipitates to maintain organ perfusion and urinary output. Cryoprecipitate is preferable in volume-restricted patients. In addition, it contains both fibrinogen and fibronectin, which facilitate removal of cellular and particulate matter from the blood via the reticuloendothelial system. Bilateral uterine artery embolization may be considered in cases of intractable hemorrhage. Rarely, hysterectomy may be indicated. Fetal management. Usually, this condition occurs after delivery, but if it occurs before or during labor, fetus is in grave danger because of maternal cardiopulmonary crisis, and so immediate delivery should be considered. Delivery of the fetus increases the chance of good maternal and perinatal outcome. Next. These are recommended, some recommended agents which are commonly used in cases of acute right ventricular failure, and the drug and doses are given in this table. Next one. And these are components of high quality cardiopulmonary resuscitation in pregnancy, in which rapid chest compressions are given and at a depth of at least 2 inches. And pulse is checked, resume chest compression immediately after defibrillating. And these are the detail of CPR. Next one. An immediate supportive therapy is shown in this table only. And we consider delivery in viable pregnancy either by operative vaginal delivery or emergency cesarean section. if fetus is equal to or more than 23 weeks of pregnancy. Next one. And Society for Maternal Fetal Medicine clinical guidelines had given some recommendations, and these are: we recommend consideration of AFE in the differential diagnosis of sudden cardiorespiratory collapse in the laboring or recently delivered woman. This is a strong recommendation. We don't recommend the use of any specific diagnostic laboratory test to either confirm or refute the diagnosis. At the present time, it remains still a clinical diagnosis. We recommend the provision of immediate high-quality CPR with a standard BCLS and ACLS protocol in patients who develop cardiac arrest associated with it. We recommend that we recommend that a multi, including anesthesia, respiratory therapy, critical care, and maternal fetal medicine, involved in ongoing care of women with AFE. Next one. Next, following cardiac arrest, we recommend in the presence of either sound आ रहा है बहुत. We recommend the provision of adequate oxygenation and ventilation, and when indicated by hemodynamic status, the use of vasopressors and inotropic agents in the initial management of AFP. Excessive fluid administration should be avoided. Because coagulopathy may follow cardiovascular collapse, we recommend early assessment of clotting status and early aggressive management of clinical bleeding with a standard massive transfusion protocols. Next one. And these are some take-home messages. AFP continues to be one of the most feared, unpredictable, and untreatable obstetric emergency. It is essential for us to maintain a high index of suspicion to facilitate easy recognition. Management includes prompt recognition of signs and symptoms, aggressive resuscitation efforts, and supportive therapy. Next. And these are the main references which I have taken to prepare this article. Next. Thank you very much. Thank you. Thank you very much.
Thank you, madam. Thank you, Rita Di. Dr. Lakshmi Sen is here, no? Madam Lakshmi.
Yeah, ma'am. Ma'am is there. Lakshmi ma'am is there.
She has to conclude that session. Where is she? I can't see her here.
Yeah.
She is
Lakshmi ma'am is there. Yeah, she is there.
Lakshmi ma'am, your audio video is not seen. I think she is not there. Dr. Supriya, you can conclude and then we'll move.
Ma'am's audio and video both are. Ma'am has on the video. Just
yes. Yes, ma'am. Please unmute yourself.
Madam, you have to unmute yourself.
Lakshmi ma'am, please unmute.
Infections. Lakshmi ma'am, unmute kariye.
Hello.
Yes, we can hear you, madam.
Thank you, Dr. Gita Jha, for your such nice, beautiful presentation. This amniotic hemorrhaging, this is a very rare and dreadful complication of the childbirth, and it requires very intensive care if diagnosed early.
Thank you, madam. So, Rita Di, I know you have made lots of effort to make this presentation. It was wonderful.
The presentation was clear or audible or not? From the
everything
beginning?
was clear. Everything,
yes, everything was clear.
Yeah. So, thank you very much. We move on to the next session, Dr. Kalpana.
Yes,
Thank you very much. Thanks a lot, Dr. Respected Chairperson, Dr. Supriya and Dr. Lakshmi Sen. Thank you. Thank you very much.
Thank you.
Thank you.
Abhishek, can you please share the profiles of next chairpersons? It's my pleasure to invite Pragya Mishra ma'am, who was a chairperson of Genetic and Fetal Medicine FOGSI 16 to 18 and consultant, fertility consultant at New Life Test Tube Baby Center and also MGM Hospital and Research Center. Madam is the Secretary General ISOPAP 22 to 24, Founder Secretary Bihar Chapter of ISAR, Vice President Patna 21 to 22, and also examiner of MRCOG clinical examination. She has received various awards, the Asia GCC Award, and also Healthcare Professional of the Year 2018, Dr. C.L. Javeri Award at 57th AICOG 2014 Patna, and Dr. Mishra Gold Medal in 2018-2020 Boxcon, and MP John Gold Medal, and she has contributed almost 10 chapters in books and papers. Organizing Secretary of FOGSI ISPAT 2018, Organizing Secretary of 24th Boxcon, organized various conferences. Welcome, ma'am, for this wonderful session. Our next chairperson is Dr. Niba Mohan, who is a consultant, Renu Maternity Center Patna, Joint Secretary Patna Uji Society, and Clinical Secretary of SOPSI, EC member of IFS Bihar, member of FOGSI Safe Motherhood Committee, Medical Disorder and Pregnancy Committee, and she's also E-Zone coordinator of Family Planning Welfare Committee, presented various papers and in national, international conferences, and received a signature award recently. Welcome, ma'am. Over to you, chairpersons, for the for further proceedings.
Good evening to everyone. Do we have Dr. Rakhi Agarwal's CV?
Yeah, I'm here. Can you hear me?
Yeah, I think you are here, but is there a CV or can
no?
I
think I
have
think
displayed
it.
No, that's fine. So at the outset, I would like to thank Dr. MC Patel for having given this opportunity to me to chair this very important session. And not only that, also thank Patna Obs and Gynae Society, President and Secretary, for this opportunity. So actually, Rakhi, I can speak about you without looking at your CV. Well, she's a young budding radiologist of Patna. And what I can say about her, that she is FMF certified. Rakhi, am I right?
Yes, ma'am.
Yeah. And not only that, what I have seen that, very few radiologists in Patna, they would chart, fetal growth according to the centiles and the PI values. So Rakhi is one of them. So if my patient, especially if IVF the patient, usually I encourage them to go to Rakhi, because so that, I can monitor their growth, because others, they would just give one value, this weight, that weight. I really do not know whether the growth and amniotic fluid is on the 3rd centile or 50th centile or the 95th centile. So that's very nice, Rakhi, and keep it up. And over to you now to speak about this topic. And I think unless Dr. Nibha Mohan, Nibhadi, if you want to speak something about it. Well, I know Rakhi is going to talk about amniotic fluid and ultrasound. And Dr. Shanti Roy, madam, initially she already said quite a bit about amniotic fluid. It can be, sometimes it can be too less, it can be too more. And we all know that, it acts as a cushion and one of the very important parameters for fetal surveillance. And a lot of, where Doppler is not available, people, obstetricians, they bank on amniotic fluid, to make their clinical judgment and to decide whether to leave this pregnancy, to continue or to deliver. So over to my co-chairperson, Dr. Nibha Mohan.
Thank you, Dr. Pragya. So let's invite Dr. Rakhi for her presentation. Let's hear this important topic, amniotic fluid and ultrasound, because we know that amniotic fluid
reflects the well-being of fetus, and she's going to talk on such an important topic, how to monitor this important parameter by a scan. So let's hear Dr. Rakhi, and then at the end we can say some more things. So over to you, Dr. Rakhi. Please unmute yourself, Rakhi. Please unmute.
Thank you,
Yes.
ma'am, for your kind words. Can I share my screen now?
Yes, you please go ahead.
Okay, so can you see my screen?
Not yet, Rakhi.
No, okay, just give me a moment.
By the way, was I audible?
Yes, yes, yes,
Was the sound okay?
yes, yes, very much.
Yes, ma'am, you are audible.
Thank you.
Okay, can you see my screen now?
Yes, ma'am. Just make it full screen.
Yes, I'm doing that. Okay. Okay, so I thank the organizers very much. I feel like a small kid in front of all the luminaries present here. I'll talk about amniotic fluid and USG. I think it's not if a holy fluid, but a magical fluid that surrounds the baby. It is contained in the amniotic sac. It surrounds and protects the baby throughout the pregnancy and provides a physical space for the fetus to move, breathe, swallow. Also helps in fetal GIT and lung development, and guards the fetus against cord compression and from trauma and infection.
Ma'am, actually it is not visible as a full screen.
Is
and
it?
Slides are not. Yeah.
No, can you see now? No?
Make it full screen, Rakhi.
I already did full screen.
No.
Ma'am,
Just a slideshow.
make it once again, ma'am. Click on escape.
Okay, so I have done just a minute. Just give me a moment.
And
Okay. I'm not able to go back to my full screen of Zoom. Should I close?
yeah. Now share it once again, ma'am. Click on share on the top or bottom, that green button, share screen.
Just give me a second. Yeah. Can you see my screen now?
Just a second. Yeah, it is visible as a normal mode,
And now?
not as a full screen.
Now it's a full screen?
No, Rakhi.
No, ma'am.
No, but I've already done full screen again.
Yeah, ma'am, but I know.
Okay, I'll start from. There was another option to play this screen, this thing, no? PowerPoint. I'm using.
Click on that on the top. There is animation besides slideshow.
Slideshow.
Okay.
Yeah.
Click on that.
So I'll
from beginning.
Now can you see it?
No, ma'am.
No, but I did from the beginning.
Yeah, ma'am.
Okay, custom from
No.
current slide. Can you see it now?
No, actually, but keep it as it is, ma'am. It is clearly readable.
I think please go ahead, Rakhi. We can hear you and we can see as well. So please move ahead.
Okay, fine. So
yes.
Okay. So
Ma'am, don't make the full screen. Otherwise, you are moving the slides and we are not. Yes, ma'am.
Okay.
Keep it in that mode only. Okay, ma'am.
Okay, fine. So early on in pregnancy, the production is mainly from the placenta and membranes, and only later on does the fetal urine production is the main component of the amniotic fluid, also accompanied by some contribution from the fetal lungs. And the circuit and the reabsorption of the amniotic fluid is mainly from fetal swallowing, also from lung absorption, GI absorption, skin absorption, and transfer across the fetal vessels into the fetus. So urine production from the kidneys start at 8 to 11 weeks, but it is not a major source until later in the second trimester. So any lethal renal abnormalities, even like bilateral renal agenesis, may not manifest with complete anhydramnios until after 18 weeks. Okay, so the amniotic fluid steadily increases throughout pregnancy, reaching a maximum at around 32 weeks, and then steadily decreases slowly to about 750 ml at 40 weeks. Assessment of the fluid volume is a marker of fetal well-being, growth, and development. And any abnormalities in the amniotic fluid volume tells us that there is a problem either with its production or circulation, and that causes either scarcity or an excess. These extremes, as with other extremes in life, are associated with adverse outcome, and we need to closely monitor it. So measurement of amniotic fluid can be qualitative or an eyeballing method. Any experienced examiner, as soon as they put the probe on the maternal abdomen, they can tell that it is an oligohydramnios or a normal fluid or polyhydramnios. So that is the eyeballing method. But if we have to quantitate it, then these semi-quantitative methods are maximum vertical pocket method and the amniotic fluid index method, about which I'll talk. These are semi-quantitative because this does not give a real estimate, but only a rough estimate of how much fluid that is there around the baby. Okay, so first, maximum vertical pocket. It is also known as the single deepest pocket or SDP. It is used for singleton pregnancies less than 24 weeks and for all twin pregnancies. So how do we do this? We keep the transducer, we hold the transducer perpendicular to the floor and parallel to the long axis of the pregnant woman. We use the sagittal plane, and then we identify the maximum vertical pocket and measure the maximum vertical dimension of this pocket. So it may contain fetal parts or cord loops, but don't include that in the measurement. And the fluid pocket should be at least 1 centimeter in width. Okay, and the normal range is between 2 to 8 centimeters. Any measurements above and below will signify poly and oligohydramnios respectively. So here I have taken sagittal in the sagittal plane along the longitudinal axis of the maternal abdomen, the maximum vertical pocket that I could identify, and then I have measured the maximum vertical dimension of this pocket, and this gives us the maximum vertical pocket dimension. Here it is 5 centimeters. So, and now coming to amniotic fluid index, this is the sum of deepest vertical pocket from each of 4 equal uterine quadrants. So it is like a maximum vertical pocket, but we are taking it from 4 parts of the uterus, and normal range is 5 to 24 centimeters. Nomograms are available. It is the most commonly used method beyond 16 weeks. Again, the transducer will be kept perpendicular to the floor, parallel to the long axis of the pregnant woman. First, we divide the uterus in 4 quadrants: the right and left, upper and lower quadrants. And then we take the maximum vertical dimension for the maximum vertical pockets in these all 4 quadrants, making sure that we are not including either the body fetal body parts or any cord loops in this section. So my probe should be perpendicular and not angulated, or we should not press too much of the abdomen, as these will all give incorrect measurements. AFI, so as I already said, it may contain fetal parts or cord loops, but don't include them in the measurement. And you should, if any doubt is there, then you use color Doppler to make sure that no cord has been included in the measurement. So here I have put on color to see that here is a cord. So I'll avoid this area and measure over here. Again, the cord is in this area, so I'll measure from here to here and not include this. Many a times cord is not well seen separately from the fluid, and you should put on Doppler whenever necessary. So what are the pitfalls when you're estimating amniotic fluid? If you put too much of pressure, it will compress the pocket and underestimate the measurement. There are, in obese women, we may have artifactual echo, especially in the superior part, and this also leads to underestimation. Free floating particles may give the appearance that fluid is less, underestimation. And if you don't take non-perpendicular pockets, if you're slanting, then may measure a longer distance and overestimation. And again, if you include pockets that have cord loops, this will again be overestimation. What do we do for twins? Here we don't use AFI, but we use the maximum vertical pocket technique. The amniotic fluid volume is stable in twins between 17 and 37 weeks. The definition is same as for poly and oligo is same as for singletons. The dichorionic etiologies are comparable to the singletons, but monochorionic, specifically, you have twin-twin transfusion syndrome, where there is oligohydramnios in the donor twin and polyhydramnios in the recipient twin, or selective fetal growth restriction, where you have oligohydramnios in the smaller baby and normal fluid in the normally growing baby. Now I'm coming to oligohydramnios. This is abnormally decreased amount of amniotic fluid. It can be seen in 1 to 2% or more of pregnancies. The definition, by definition, it is an amniotic fluid index less than 5 centimeters or a maximum vertical pocket of less than 2 centimeters. We may also use nomograms that are there for the gestational age, and then we take it either as less than 5th centile or less than 2.5th centile. If no measurable pockets are identified, then we use the term anhydramnios instead of oligohydramnios, meaning complete lack of fluid. This is an example of a nomogram. So with gestational age, the fluid increases and then decreases, and this may be used to plot the amniotic fluid or AFI or MVP. So what are the causes of oligohydramnios? We have 3 main causes. The first one is premature rupture of membranes, which will be evident if you take the history. The second one is placental insufficiency or fetal growth restriction. The baby will be smaller. And thirdly, the fetal structural abnormalities, mainly the kidney and bladder outlet obstruction. These you'll identify if you go systematically through the baby and its anatomy. Whenever we have an early onset oligohydramnios, it's either a fetal structure abnormality, a severe fetal structure abnormality that is preventing urine formation, or it is a placental abnormality that is preventing a major placental abnormality, preventing adequate perfusion. And this is commonly a poor prognosis condition. Very rarely I have seen a baby with an early onset oligohydramnios survive and have a good outcome. Whereas after mid-pregnancy, if you have oligohydramnios, this is mainly because of fetal growth restriction, placental abnormalities, or maternal complications like preeclampsia or vascular disease. Here you must evaluate whether the membranes have ruptured by careful history taking and evaluate the fetal growth. So this is a case of FGR at 35 weeks with almost very little liquor. The AFI here is 2.6 centimeters. This is a case of premature rupture of membranes at 38 weeks with almost nil liquor. AFI is 1.8 centimeters. This is a case of bilateral renal agenesis at 20 weeks where the bladder was persistently empty. The fluid is nil. And instead of the kidneys, we can see the adrenals in a lying down vertical position, which is typical for this abnormality. So next I'm coming to polyhydramnios, which literally means too much of fluid. Okay, so polyhydramnios, then by definition is more or equal to 25 centimeters by AFI technique, or more and equal to 8 centimeters on the maximum vertical pocket technique. And for twin, it is more than equal to 8 centimeters in the maximum vertical pocket technique. It is the severity can be graded based on whether it is what is the severity as mild, moderate, and severe. The AFI will be 25 to less than 30 centimeter for mild, 30 to less than 35 centimeter for moderate, and more than 35 centimeter for severe polyhydramnios. Again, here the main causes are, number one is idiopathic, where you don't find a cause. Then maternal hyperglycemia, which may be gestational diabetes mellitus or pre-existing diabetes mellitus. You will know it from the history, or if you are doing a GTT or from seeing other parameters. Generally, these babies are also macrosomic. And then obstructive GIT abnormalities, which are commonly seen in this group of fetuses, and congenital infection and fetal anemia or a hyperdynamic fetal circulation. This is mainly imbalance between the fetal swallowing, which is reduced, and fetal urination, which is increased, causing the polyhydramnios. I'll just quickly show a few cases of polyhydramnios. So this is a cleft lip palate, bilateral cleft lip palate with polyhydramnios. Because of decreased swallowing, the baby cannot swallow well. This is a case of esophageal atresia. The stomach bubble is not seen, and polyhydramnios, and the hypopharyngeal pouch is there. So there is obstruction to swallowing beyond the stomach, beyond the esophagus, because it is not communicating with the stomach. This is another case of esophageal atresia, small stomach bubble, then the hypopharyngeal pouch, and polyhydramnios. This is a case of fetal anemia or hydrops. You can see scalp edema, massive ascites, pleural effusion, polyhydramnios, and increased MCA, PSV, which tells us that this baby is severely anemic. Another cause is anencephaly, where whole brain is exposed, polyhydramnios with echogenic amniotic fluid, and GDM, which is very common with polyhydramnios. You see GDM, the fluid is increased, and the measurements are high, going above the 95th percentile. And also severe skeletal dysplasia, because the baby cannot move well. So the movement of the baby is also important for proper amniotic fluid circulation. Now coming to echogenic amniotic fluid, this can be seen in 4% or more of the pregnancies. In the first trimester, it is amounted to mainly because of hemorrhage, but in second and third trimester, most common cause is shedding of the vernix caseosa, which is the fetal skin and hair. And this is the most common cause. Many a times I come across questions, the echogenic fluid is it bleeding? But no, that's an uncommon cause, and the most common cause is shedding of the vernix caseosa. And it can also be because of meconium and hemorrhage into the amniotic fluid, or sometimes in anencephaly, I can see it when the brain tissue has totally liquefied and made the fluid echogenic. Here, this was the case of anencephaly with very echogenic fluid. So let me go through the key points quickly. The normal amniotic fluid volume is between 5 to 24 centimeter on the AFI technique and 2 to 8 centimeters on the maximum vertical pocket techniques. For twins, please use the maximum vertical pocket technique. The AFI will not work. In the early oligohydramnios is associated with a poor prognosis, whereas polyhydramnios is also leads to many a times poor outcome because of preterm delivery, mainly especially when it is severe. So when doing USG in amniotic fluid, keep the pressure light, keep the transducer sagittal and perpendicular to the floor. Use color if needed to differentiate from the cord. In suspected polyhydramnios, measure the AFI. In oligohydramnios, measure single deepest vertical pocket. Whenever you have an abnormal Leica volume, please look for maternal disease or fetal structural abnormalities and follow the progression with USG. I thank you very much for your kind and patient listening. I thank the organizers and for giving me this opportunity. And now I'll stop the share. Thank you.
Thank you, Dr. Rakhi, for your wonderful presentation of such an important topic. Like amniotic fluid assessment has been an like guidelines also say that is an integral part of fetal assessment while doing scan. So it's very important for us obstetrician doing scan to know the exact way to express amniotic fluid details, measurements of amniotic fluid, because many of the obstetricians are doing scan these days. So apart from the fetal details, the amniotic fluid details should be also very specific to make the things clear. And beautifully, you have explained all the details about measurement, about eyeballing and the semi-quantitative measurement. And pitfalls also you beautifully mentioned, that not much of pressure, not inclusion of cords, and how to measure in twins, and echogenic amniotic fluid, everything you made clear. And just one thing I wanted to see, like one of your slides showed a single deepest pocket in less than 24 weeks. So after that, we don't do SDP?
No, ma'am, we can do it, but AFI is preferred. It's preferable after advanced pregnancy.
AFI is preferable. So that's important for us, for all the delegates also. So these small points you made so many clear. And is there any significance of ELARA, like as little?
And the current USG machines are very safe. Even if you are scanning the patient for a long time or repeatedly, you are absolutely safe.
Okay. So on patient request also, many a times it's request from patient side. Madam, please देख लीजिए सब ठीक है कि नहीं, पानी ठीक है कि नहीं. So it's all good. So thank you, Rakhi, for all the details, all the wonderful presentation.
Thank you, ma'am.
And thank you, organizers, for the.
Can I just have I just wanted to say something.
Yes, yes.
Yeah. Rakhi, it was indeed a very nice lecture. And Dr. Nibha Mohan has already mentioned that, you have given very good key points and pitfalls and everything. My question was that, until a decade ago, we were all talking about, AFI. But recently, now people are saying that they have all recent guidelines are saying that they are moving to single deepest pocket or maximum vertical pool. So that is, you mentioned that in twins, we have to go for single deepest pocket, and but otherwise, AFI. But recent guidelines, because I myself gave a lecture on amniotic fluid measure right, act right, and where people asked me that question, and that was in Gorakhpur, and this was that whether you would go for AFI or single deepest pool. So all the stalwarts there, they said that latest is single deepest pool, and we don't take AFI into consideration. But I have the habit of always writing fetal growth and AFI. So. So can you just comment on that?
Yes, ma'am. All the recent studies are saying the amniotic fluid volume measurement, exact measurement, say in oligohydramnion or in normohydramnion. It's not so important as if you have a decent enough pocket more than 2 centimeters on MVP, it is good enough. But means they are saying that the importance of amniotic fluid assessment for fetal well-being and outcome is not as important as it was thought earlier. Earlier, we thought that if there's the AFI is coming a little less, then we should immediately deliver the baby. So that importance has lessened, and they are saying that even, we still attach our importance, our nostalgia for AFI is still there, and we still continue to use it.
Because when I was undergoing training in England, that time, everybody was shifting to AFI. And then just recently, about since 2 years now, they are saying go for MVP. So for example, if a patient's AFI is less, is just about 6 or 7, but maximum vertical pool is 2 to 3, then that means there's no reason for haste. Am I right?
Yes, ma'am. You're absolutely. Yes, ma'am. You're absolutely right. So recent studies are lessening the importance.
The audience would be that don't go by the AFI, go by the maximum vertical pool. It is more significant of fetal health that way.
And Pragya, she's mentioning that deepest pocket is especially before 24 weeks, and after that, she's stressing on AFI. So I'm not finding what exactly the cause may be.
No, but what I'm saying, I'm not arguing, but I'm just saying that what all the
you are totally right. Recently, everyone
they all said, like Minu Agarwal and all, who was the chairperson of Imaging Science Committee. They all said, that we are all shifting to our deepest vertical pool now. So we are not going for AFI. So that's why I just commented. I still write for fetal growth and AFI. Every prescription I write, But I was thinking whether, that's wrong on my part. Anyway, very nice lecture.
Yes, very good. Very practical tips also. So thank you, Rakhi, and thanks organizers, especially Dr. MC Patel, sir, leader of this Happy Learning Master Classes. And we are really happy in attending these happy classes. And thank you, our President, Dr. Vinita, and Secretary, Dr. Supriya, also for giving us the opportunity. So thank you. And over to organizers for the next session.
Yeah.
Thank you. Thank you so much, Sakshi ma'am, for the really wonderful lecture, and to the chairpersons, Nima ma'am and dear Pragya ma'am. So moving to the third, and really, I am really very excited. I always excited to learn and listen to our own respected MC Patel sir. So third lecture is all about the medical legal of the amniotic fluid abnormality. And to chair this session, we have a very dear to seniors with us, Dr. Vinita Singh ma'am and Dr. Kalyani Singh ma'am. So can I have the CVs? Vinita Singh ma'am, we all know ma'am is Associate Professor, Department of OBG at NMCH Patna. At present, she is the President, Patna OBG Society. Post held the Foxy ICOJ Governing Council member, Young Talent Promotion Committee, Chairperson Foxy 2017 to 19, Joint Secretary, Clinical Secretary, Treasurer, Vice President, Executive Member of POGS, Member of the Safe Motherhood Committee, Quiz Committee, Practical Obstetric Committee, Foxy, Business Secretary of the Patna Journal of Medicines, East Zone Coordinator, MTP Committee, Foxy. She has many conference in her capacity, like the secretary or invited faculty, and a lot of award in her category. Thank you so much, ma'am, for giving us the time and agree to be the one of the chairperson of this session. Next is Dr. Kalyani ma'am. Ma'am is the professor of OBG department at Lord Buddha Kosi Medical College, Saharsa, founder, member, and vice chairperson of Lord Buddha Kosi Medical College Hospital, consultant Kalyani IVF, consultant PK Hospital, New Colony, Saharsa, done more than 16,000 major surgery, include 5th and 6th cesarean section. It is really a wow. Founder, member, and president of the Saharsa OBG Society, published many papers in research, international, national journal, member of the editorial board of the Journal of Gynae and Obstetric Advance, that is in UK. So I really like to welcome Dr. Kalyani ma'am or Vinita ma'am, and I request Dr. Vinita ma'am to invite our next next speaker, that is our own very Dr. MC Patel sir. Over to you, ma'am.
Thank you, Purva, for your such a wonderful words. Once again, good evening to all of you. In this the next session, we have as a speaker a very famous medical legal counselor as well as obstetric and gynecologist, none other but Dr. MC Patel from Ahmedabad, who is also director of this Happy Learning programs, Happy Learning classes of webinars. And once again, I would like to congratulate you, sir, for having such a huge number of webinars pan-India. He was Vice President Foxy 2018 when I was YTP Committee Chairperson Foxy, and I had seen working Dr. Patel in such a nice way. He was Organizing Secretary AICOG 2017. He was Chairperson Ethics and Medical Legal Committee Foxy 2011 to 2013. Honorary Joint Secretary State Organization of Gynecologists and Obstetricians of Gujarat 2019 and 2021. Organizing Chairperson MMCon 2018. Honorary Member National Inspection and Monitoring Committee, PNGT Act, Government of India 2015. Honorary Member State Supervisory Board, PNGT Committee, Gujarat State 2005 to 2009. President Ahmedabad Obstetric Society 2010 to 2011. Honorary Member National Managing Body, Indian Red Cross Society, Headquarter 2019 to 2022. National President, National Medicos Organization 2016 to 2018. President IMA Ahmedabad Branch 2007 to 2008. And so on, sir. So, really, we are very excited to hear you on the legal issues.
Thank you for kind words, and let me share my screen and straightway to the subject. So, is my screen seen? Full screen?
Yes.
Hello?
Yes, sir.
Yes, sir, it's visible.
So, greetings from Statue of Unity, tallest statue of world, and we all are proud of that statue. And to visit that statue, I invite you all to be a part of 45th, that is SOGO conference, that is State Conference of Gujarat, going to be happened on 9th, 10th and 11th December, hosted by Ahmedabad OBGYN Society, but it is destination conference, and you are most welcome to be part of this conference. You will have a very unique experience. So warm welcome all the delegates and wishing you a litigation-free practice. At the outset, I would like to thank all the society who have joined today's webinar, Katiyar, Patna, Sahasra, and Sitamarhi, and all the president and secretaries of respective society. And again, particularly Dr. Vinita Singh and Supriya Jaiswal Madam in particular for helping us to come to this webinar. So legalities or legal issues in amniotic fluid abnormality. Usually I start any of my talk with this question: is it worth discussing? Yes. And if it is yes, then why? Because medical legal litigations are increasing in number constantly and steadily, and unluckily we gynecologists rank first. So let us see. This is real happened case in city of Ahmedabad only. Regular antenatal checkup, sonography every time, told everything to be normal except polyhydramnios. At 34 weeks, it was sudden intrauterine fetal death. It was diagnosed on routine antenatal checkup. Advice cesarean section, preoperative investigations were advised, and blood sugar came out to be 432, which was never done before. So in this type of case of polyhydramnios, why we should be vigilant not to end up into this type of mission. So case was filed, notice was served, compensation demanded 1 crore. Still case is on, result has to come. So where thing went wrong in this type of situation? Usually in this type of situation, very important question comes on part of prosecution. Was it preventable? And in this particular say, you cannot say no, it was not preventable. If at all you would have gone for blood sugar and GDM was diagnosed, and if it would have been a controlled GDM or well managed, then this might have been prevented. So if it is yes, then why you couldn't prevent it? This would be the one more question whenever you are facing this type of litigation. Let us see, very important case. This case happened in state of Madhya Pradesh. In this particular case, sonography for fetal well-being was advised by gynecologist, and sonography was done by radiologist, sonologist. 20 weeks, 6 days gestational age with no abnormal finding. Fetal spine, trunk, and limbs are normal. After 3 months, again, gynecologist advised sonography, but this time patient went to another sonologist. Findings were 32 weeks on 22nd, 4th, 2009. So on second sonography, 32 weeks, 1 day pregnancy, severe oligohydramnios was the diagnosis. But again, it was mentioned that fetal spine, trunk, and limbs are normal. So considering both the reports, gynecologist continued treatment till May 2009. Patient went to Devas in so many of states, even in Gujarat also, and in Madhya Pradesh. First delivery is conducted at maternal place. So patient from Indore went to Devas, and delivery happened at Devas, and she delivered female baby of 1,500 grams baby. But fact was this: absent left upper limb, absent left kidney, lungs not fully matured, fused spine cord was found. Pediatrician was consulted with other expert. Surgery was advised for correction of neck and spine deformity. Chances of paralysis was explained. And as there was single kidney, chance of renal failure was also opined by forensic medicine department of that particular place. So case was filed, depends on part of first sonologist. 30 years experience in radiology with sonography, and a gynecologist requested to confirm duration of pregnancy only, and she did basic routine sonography following standard procedure with due diligence. Organ imaging depends upon position of fetus, and absence of organ could be visualized with most difficulty. Routine prenatal sonography is very basic scan and lasts only for 10 minutes, during which position of fetus cannot be changed to view it from side. And every gynecologist and radiologist is fully aware of inherent limitations of such sonography. But it was very poor defense, because you cannot say you had only 10 minutes to examine. So this was the inference, defense taken by first sonologist. Again, she also continued with the argument that fetus was lying on its side with upper limb tucked underneath, so it was impossible to see that any limb was missing, nor was there any reason to assume or support. Congenital anomalies suffered by fetus rather very rare and extremely difficult to detect, even with repeated examination with best expertise. Because difficult to detect is also not palatable, because this much anomaly one cannot afford to miss. So again, she went with defense. Routine scan cannot detect such anomalies. It needs advanced targeted and anomaly scan, and it should be advised by treating doctor. Radiologist, sonologist would not do by his own, and she gave reference of Culling's book. Second sonologist said defense that gynecologists advise sonography for gestational age only, and sonography was done for that only, and charge was also collected for the same. Purpose of obstetric scan is to see fetal growth and gestational age of baby. In small proportion, gross malformation may also be detected. Type of examination depends upon the request from gynecologist who has referred the patient. But inference held by the commission by report of both the sonologists and defense taken by both the sonologists. If radiologists couldn't see limbs due to tucked posterior abdomen, and how both of them opine that fetal spine, trunk and limbs were normal, it was very casual approach on part of radiologists. It was observation and inference by National Commission, and dereliction of duty of care was considered. So compensation of worth rupees 15 lakhs was awarded in favor of patient and relative in this particular case. So again, in this type of situation also, where thing went wrong, was it preventable? Naturally, this much anomalies one cannot afford to miss. So if it is yes, then why you couldn't prevent it was the question. And was it possible to detect anomalies in time, and where these anomalies were rare or difficult to diagnose? And if radiologists couldn't see limb due to tuck position, then why both of them opine fetal spine, tongue and limbs normal? So this was inference held by the court. So in this type of situation, carry-on message is never report normal if you couldn't see any part due to position of fetus. You can advise repeat scan, or you can advise opinion from others also, and ensure that you will not miss any important finding in this type of situation. So when you are dealing with either a case of polyhydramnios or oligohydramnios, you should be vigilant enough to detect any anomaly if at all it is there. Let us see case number 3. It is very important case happened with our own Foxian friends in Ghaziabad, our own friend Dr. Manisha. So history of patient was like this: patient admitted with labor pain. She was in good health at time of admission, no satisfactory progress. Cesarean section was advised. Patient and relative were reluctant to give consent. So doctor was constrained due to non-cooperation on part of patient. So she said, either you give consent or you are free to take patient to another hospital. And then after only consent was given, cesarean section was done. After delivery, patient suddenly developed cardiorespiratory arrest. Amniotic fluid embolism was suspected. Patient was intubated and started positive pressure respiration immediately. Patient showed sign of partial revival. Cesarean section was completed very quickly. Relatives were informed about sudden happening and serious condition of the patient. Thereafter, patient was shifted in ambulance to nearest tertiary care center with positive pressure respiration. In the same ambulance, Dr. Manisha accompanying the patient. The patient was put on ventilatory support in that tertiary care center. Patient responded, but ultimately she developed cerebral hypoxia and she went into vegetative form and expired during the course of treatment. So case was filed and a complaint filed before Uttar Pradesh Medical Council and before Uttar Pradesh State Commission, and compensation demanded rupees 99 lacks. Point in issue was whether there was any negligence or any deficiency in service while managing patient and performing cesarean section. So Uttar Pradesh Medical Council gave inference that didn't hail Manisha Agarwal for procedure lapse or negligence while performing cesarean section, but ethical committee opined that Manisha Agarwal should be restricted to operate in such facility which seems not up to mark. And Chief Medical Officer Ghaziabad should be informed that Manisha Agarwal will not operate in this hospital unless facilities are improved. So as far as opinion from Medical Council was concerned, she was not held negligent as far as performing cesarean section and managing the case of amniotic fluid embolism. But State Commission verdict was held Manisha Agarwal responsible and awarded compensation to the complainant. So she preferred appeal in National Commission. And now our medico-legal team entered in this particular case at the level of National Commission and see how it changed all the scenario in National Commission and ultimately in Supreme Court. So observation on part of National Commission and inference held by the National Commission was, in order to succeed the claim in medical negligence, any case, three requirements needs to be met. One is accidental nature of misconduct on part of doctor. Second, existence of proven damage occurred to the patient. And third part, it should be direct relationship of action taken by doctor for damage to occur. So doctor shall put in place all necessary measures as to the current scientific knowledge. It was inference by National Commission. So gynecologists perform her duty with reasonable standard and as per accepted practice. The patient was appropriately referred to higher center. So in this argument, during this National Commission, in this particular case, we took reference of Williams obstetric. Amniotic fluid embolism, it is very nicely prescribed in, described in Williams obstetric, and we took this reference of this textbook, and we could convince National Commission that amniotic fluid embolism is rare but often fatal complication of pregnancy. Onset can neither be predicted nor prevented, because in this type of case, on part of prosecution, question is asked, was it preventable? But as far as amniotic fluid embolism is concerned, neither be predicted nor be prevented. Infrequent, unpredictable, the catastrophic complication causing cardiovascular collapse, and virtually impossible to predict which patients are at risk of amniotic fluid embolism. Diagnosis must be based on spectrum of clinical signs and symptoms by exclusion of other causes, and it is nicely covered by our previous speaker also. So further we went with this, that amniotic fluid embolism is a syndrome typically occurs during labor, soon after vaginal or cesarean delivery, or during second trimester dilatation and evacuation procedure. So we could convince National Commission with this reference. It is virtually impossible to predict which patient are at risk, we could convince. So further reference was taken from Williams only. Most cases of amniotic fluid embolism are associated with dismal maternal and fetal outcome regardless of quality of care rendered. So whichever efforts taken on part of gynecologists, outcome cannot be predicted and cannot be expected as per your wish. Early recognition of amniotic fluid embolism with prompt intervention is paramount to a successful outcome. Management is resuscitative, maintaining vital signs and treating hemodynamic and coagulopathy derangement as they occur. A team approach among obstetrician, anesthesiologists, and intensivists is necessary for successful outcome. So in this type of reference, when we treat this type of patient at multi-speciality approach, involving our professional colleague, other senior gynecologists or anesthesiologists or intensivity, it shows your consent to save life of patient. So despite early intervention, maternal and fetal mortality remains high. So this reference from Williams was very much useful in this particular case. Further, we took this reference also, in William Obstetric also. Long-term consequences will depend on the severity of cerebral anoxia and on how much irreversible damage has occurred in the brain. If there has only been mild or short-lived anoxia, there may well be recovery back to normal or near normal level of functioning. However, if the anoxic injury has been more marked and then outcome is less certain, and there are likely to be long-term effects. So we could convince court with this reference also. And nature of these problems will vary from person to person, and depending upon the severity of injury to the brain and area of brain affected. And accurately predicting those who will achieve a good neurological outcome in post-arrest comatose patient is very difficult. We also went with one more reference. In this particular case, in Supreme Court, Supreme Court has taken this reference that skill of medical practitioner differs from doctor to doctor, and very nature of profession is such that there may be more than one course of treatment which may be advisable for treating patient, and courts would indeed be slow in attributing negligence on part of doctor if he has performed his duties to the best of his ability and with due care and caution. So in this particular case, in Supreme Court, it was inference held by the Supreme Court also. The skill of medical practitioner differs from doctor to doctor, and this we have already discussed. So medical opinion may differ with regard to the course of action to be taken by a doctor treating a patient, but as long as doctor acts in a manner which is acceptable to the medical profession. So if you have managed case as per standard medical norms or as per any prudent gynecologist would have attained, then it is safer as far as litigation part is concerned. But as long as doctor acts in a manner which is acceptable to the medical profession, and court finds that he has attended on patient with due care, skill and diligence, then if patient still doesn't survive or suffers a permanent ailment, it will be difficult to hold doctor to be guilty and negligence. So it is very important case decided by Supreme Court and a very landmark judgment in favor of gynecologists in this type of situation. So whenever we are facing this type of litigation, we take based of this type of cases decided in Supreme Court. One more case was taken into consideration at the time of deciding case of Manisha Agarwal. And in this case also, it was also decided in Supreme Court. Apex Court, while dismissing the complaint, held that Consumer Protection Act should not be halter round the neck of doctor to make them fearful and apprehensive of taking professional decision at a crucial moment to explore possibility of reviving patient hanging between life and death. And doctor in complicated cases have to take chance, even if the rate of survival is low, and doctor faced with an emergency ordinarily tries his level best to redeem the patient out of age suffering. So in this case of Manisha Agarwal, taking base of all those cases decided in Supreme Court, National Commission went with this observation that gynecologist is qualified as an obstetrician and experienced one. Cesarean section was performed as per standard procedure, but unfortunately, patient suffered cardiac arrest due to unpredictable amniotic fluid embolism. Though immediately resuscitative steps were performed by doctor in OT, but patient suffered cerebral hypoxia, and it was not due to negligence or deficiency while conducting cesarean section or management of amniotic fluid embolism. So it was very good observation on part of National Commission, but it was only due to all the bases we took from Williams and strong argument on part of medical legal counselor. So State Commission has erred in law to hold it as a medical negligence it was inferenced by National Commission that taking judgment to make Dr. Agarwal negligent by State Commission was erring and it was hasty step. So in this instant case, based on foregoing discussion, order of State Commission is set aside and first appeal is allowed and consequently complaint is dismissed. So this case was decided in favor of our own Dr. Manisha Agarwal from Ghaziabad in case of amniotic fluid embolism by National Commission. So this is landmark judgment happened in this particular case. So whenever we are facing any kind of litigation related to amniotic fluid abnormality, whether it is due to poly or whether it is due to oligo or amniotic fluid embolism, there are certain areas and all those questions we have to answer. I just have mentioned prior also. Was it preventable? Yes. What did you do to prevent it? Why you couldn't prevent it if at all you couldn't prevent it? Then did you diagnose in time? And did you manage way in which any prudent doctor would have managed? So every amniotic fluid abnormality is potential threat as far as litigation part is concerned. And many a times treating serious patient could be suicide as far as medical legal problems are concerned. So many times questions come, look like avoiding medical legal problems in our practice is a difficult balancing act. No, not at all. Then what to do and how to prevent? So only three important points you have to practice in your day-to-day practice. Practice foreseeability, that is anticipation, good communication and proper consent, and proper documentation, and you will be simply sail through. As far as foreseeability is concerned or anticipation is concerned, you should anticipate certain complications. Say, for example, if you are dealing with a case of polyhydramnios, so you should anticipate all the probable complications related to polyhydramnios. Or if you are dealing with a case of oligo, then same way you have to foresee or anticipate all the complications, and you should be readily available to deal with situation accordingly with all intensive care if at all it is needed. And proper counseling is very much important. So if you are facing with a case of poly or oligo, then you should have very proper counseling with patient and patient party, with outcome of your management, with all possible complications and prognosis, because communication is key to avoid litigation, and it is very obvious. We might have the best medicine in the world, but it won't be successful if patient doesn't understand it. And it should be in a very simple language, no much medical jargon, no rosy picture, no tall claim about result. Because in eye of law, when you claim to be master, you are supposed to be master. So no tall claim, no rosy picture. Because in our obstetric practice, we consider our result like Aishwarya Rai, but it may turn like this at any time. So no rosy picture, no tall claim. So proper communication, proper documentation is very much important. And when you take signature on consent paper, it becomes a documentation of your communication. And when you offer all the papers in court of law, it becomes a communication of your documentation. So records are always at your rescue. So keep them up to date. What was done, nothing was neglected, given treatment fully met with standard demanded by law and ethics, and it should be easily acceptable whenever offered by in the court by doctor. Sorry. Because doctor is bound to produce record whenever asked by the court, and if he doesn't, then adverse inference might be drawn. And it is very obvious, good record is good defense, poor record is poor defense, and no record is no defense. And it has been my experience during my medical legal practice. We doctors' friends are very poor as far as record keeping is concerned. This gentleman has so many staircases, but he doesn't know how to use them. So it doesn't matter how many resources you have. If you do not know how to use them, they will never be enough. There are so many provisions in law also in your favor. But if you do not know how to use and when to use, then it will be useless. So have some basic legal knowledge. Always obtain medical legal advice whenever you are in doubt. In spite of all these professional and occupational hazards, our journey to serve human and mankind is always on and on. And if you want to sleep like this, I end my talk like this also. Take attention to your patient, take tender care of your patient rather. Pray Almighty God before going to sleep and keep my visiting card below your pillow. So be vigilant in your practice. Take medical legal advice from point 1. Whenever you are in little doubt, whenever you are served with a notice, or you are asked to submit record to even patient or anybody, when a patient or patient party or anybody asks a record, then be vigilant. There is something going to happen. So be vigilant and have a phone call to medical legal advice before you submit any record to anybody. And this is law of leopard behind innocent gynecologist. This is my Takia Kalam. And see the role of medical legal counselor, how he can be useful in any given situation. So please do not hesitate and take help and advice from medical legal counselor. So God bless you. Have a litigation-free medical practice. With regards, salute to all the societies who have joined this webinar. Thank you very much. Please do not assume. Please ask if any query or question, if chairpersons and time permits. Thank you very much.
Thank you so much, MC Patel, sir. Sir, your talk is always an enlightening and it's really mesmerizing and eye-opener for all of us. I really, sir, I think I have listened your talks n number of time, and every time it's a new thing for me. So thank you so much, sir, for really wonderful talk. I would like to invite the chairperson, Kalyani ma'am, to have the comments. Ma'am, over to you.
Good evening, everybody. When I knew about this topic, I searched it. It was new for me, and I searched it on Google to know something about it. But I found nothing about this on the Google. It was, and I was keen to hear this. I was keen to hear Dr. MC Patel. So it was such a beautiful presentation and such a mesmerizing presentation that my attempt to judge this presentation will be like that, जैसे कि सूरज को दिया दिखाने जैसा. So I am not the right person to judge him. So I am feeling proud and privileged that I have been invited. I have been given the honor to chair the Dr. MC Patel. And there is nothing to. It was such a beautiful presentation. There is nothing to say about it.
Thank you, ma'am.
Thank you, sir.
Thank you so much, ma'am. Ma'am, Vinita, ma'am.
Yeah, thank you, sir. It was such a mesmerizing talk, and really always I love to hear you. And what I have learned, and always we are learning from you, that proper documentation is very important. And even proper counseling, proper communication is also very important that can avoid so much litigations, and we are not able to be felt guilty in any case. So proper documentation is very important, and we have to learn this. So thank you very much, sir, for giving such a wonderful talk.
And you
I have a question.
Proper documentation is very much a must, and consent is part of your documentation. And in very famous case of C. Jaipal Reddy versus Padmini Velluri, National Commission has very specifically mentioned that consent paper is not mere piece of paper where patient or relative has to sign, but it is a very important document of your communication or counseling. Whatever you have counsel, you have to enter in that consent paper, and then patient has to sign. But not to remember all this, you have to simply visit Foxy website, and on Foxy website, it is available with Foxy Uniform Consent. We three medical legal experts, Dr. Dilip Balke from Pune, Dr. Nikhil Datar from Mumbai, and myself, Dr. MC Patel from Ahmedabad, we have prepared almost different 30 consent, say for cesarean section, say for hysterectomy, abdominal, vaginal, endoscopy, medical termination of pregnancy, medical, surgical, HSG, treating critically ill patient, referring to higher center, anesthesiologist consent, then consent for blood transfusion. So we have taken much pain, and at the time of deciding this consent and putting on Foxy website, we had a collaboration with Maharashtra Law Society, and we had a ample discussion, many a time for one word or one line, for hours together with learned faculties from Law Society of Maharashtra, 2 retired High Court judges, 1 sitting High Court judge, 1 judge in National Commission, who has given this judgment of Manisha Agarwal only, Dr. Kantikar, good friend of mine. And we had a discussion with him also. And then only we have come up with all those consent. So you have to simply download this. Almost 30 consents are there, and you can utilize in your day-to-day practice. Of course, it is in English, but if at all your society can take to translate it in Hindi, then I will be more happiest person. In state of Karnataka, just in last week only, there was state conference at Hubli, and they have translated all those 30 consent in Kannada, and they have published book, and they gave this book to all the delegates of that conference. So Bihar also can take lead to translate in Hindi. I will be happy as well. I will be assisting anybody, and you can share. One can translate 3-4 consent. One other person can translate 1-3-4 consent, and we may come up with all the version in Hindi also. So thank you very much.
Thank you so much, Speaker, respected Dr. MC Patel sir, and the chairperson, Vinita Singh ma'am and Kalyani Singh ma'am, for chairing the session. So moving to the very exciting part, that is panel discussion. And for that, I would like to invite Dr. Supriya ma'am to introduce the moderator. Over to you, ma'am.
Thank you, Dr. Apurva. So now we come to the much awaited panel discussion on troubleshooting in amniotic fluid abnormalities. So to moderate the session, we have Dr. Jyoti Malhotra. The moderators are Dr. Jyoti Malhotra. She is Senior Consultant OBGY Kurji Holy Family Hospital, Patna, and Dr. Monica Anand. She is Additional Professor, Unit Head, OBGY AIMS, Patna. So Dr. Jyoti Malhotra is the Senior Consultant at Kurji Holy Family, and she is active member of ISOPAB, Joint Secretary Patna PARB. Then she has presented papers in state and national conferences. She has special interest in high-risk pregnancy. So I welcome you, Dr. Jyoti Malhotra. Next is Dr. Monica Anand, who is Additional Professor at AIMS, co-authored 2 books, published more than 35 research papers. She is peer reviewer of BMJ, case reports, Achiever Gynecology and Obstetrics, GOG research, cancer reports, state level resource person for MIYCN training, then clinical secretary Patna chapter of PAB, then co-chairperson Urogynecology Committee POX, quiz committee POX, and then she has got special interest in gynae endoscopy, gynae oncology, and high-risk pregnancy. I welcome you, Monica.
Thank you, ma'am.
Yeah. Then there are experts. We have Dr. Sneha Buyar, Chairperson Breast Committee FOXI, and Dr. Rekha Rajendra Kumar. She is Vice President, Bengaluru OBGY Society. So we have, do we have Dr. Sneha Madam here?
No, Dr. Sneha Madam has sent her apology. She is unable to join. So we can go with Dr. Rekha only.
Okay. Yes, sir. So Dr. Rekha Rajendra Kumar, can we have the CV? Move forward the CV, please. Yeah. Madam is a gynecologist and IVF specialist, diploma in human resources development, diploma in health and hospital management, and she is also diploma in hospital administration. She has been awarded with many awards and achievements, first rank in MD University examination, then 7th rank in Bangalore University, all India topper ICOG reproductive medicine examination, 13 awards and 3 felicitations, including 1 international and 3 state awards. She has been the practicing gynecologist for more than 30 years, Vice President BSOG, South Zone Coordinator, FOXI Infertility Committee, Chairperson Infertility and ART Committee, Kasuga, 2020 to 22. She's peer reviewer of Jogi, ex-PG teacher of MS Ramaya Medical College and Bangalore Baptist Hospital. Then founder EC member of 4 years, past member of FOXI Sexual Medicine Committee, Endocrinological Committee, and Food and Drug Committee. Joint Organizing Secretary of Abhigyan 2021, FOXI FIGO CEFOC BSOG International Conference. She had been the chairperson, speaker, moderator, panelist in more than 500 state, national, and international conferences. She's been the life member of many associations. She has many publications to her credit, 1 case report and 9 original articles, 1 poster presentation in HRA Conference 2021, more than 100 radio and television talks, 40 news paper articles, all on women's health. So with these words, I welcome you, Dr. Rekha Madam. And the wonderful panelists, we have Dr. Ranjana Jha, Secretary, Katihar OBGY Society, Dr. Lata Gupta, Secretary, Sitamarhi OBGY Society, Dr. Charu Modi, Chairperson, Adolescent Health Committee of Patna OBGY Society, a very active member, Dr. Shraddha, Director, Niranjan Arogya Niketan and Research Center, Patna, Dr. Vinita Sinha, Patna OBGY Society, she is an active member of our society, Dr. Sangam Jha, Associate Professor, AIIMS, Patna. So these are the panelists. So briefly, I can tell you they are all active members. Dr. Ranjana Jha, she had been the Secretary of Katihar Seva Sadan, formerly Associate Professor, MGM Medical College, and she is is health. She's been awarded with Health Minister Award for contribution in Surakshit Matritva Abhiyan. This was her main administrator, Katihar, and many other things. She is very interested in social work. Next. Dr. Lata Gupta, she's the founder secretary of Sitamarhi OBGY Society and past president of Lions Club, then chaired sessions and many, she's a very active member. Actually, she takes keen interest in all the panels and everywhere, wherever she's invited, she's readily, she accepts the invitation to be the panelist and she discusses very well. So welcome, Dr. Lata Gupta. Next, Dr. Charu Modi. She's the Chairperson Adolescent Health Committee for POS 2021 and 22, Chairperson Public Awareness Committee. She was very actively, she has done her work in these committees. She has been a member of Foxy Breast Committee, YTP Committee, Public Awareness and Medical Disorder in Pregnancy Committee. She's the convener of Scientific Committee where she was there in the convener in 57th AICOG. Then she has got many publications to her credit and she has been awarded with Dr. MP John Award, or Dr. Reddy's Traveling Fellowship Award, Dr. D. Singh Traveling Fellowship Award. Overall, she has got special interest in programs related to public awareness, cancer screening and safe motherhood. So welcome, Dr. Charu. Dr. Shraddha, she is the director of Niranjan Arogya Niketan and she is a very active member. She also takes keen interest in all the discussions of the scientific care. So welcome, Dr. Shraddha. Then Dr. Vinita. She is Assistant Professor, Department of OBGY at NMCH Patna, Co-Chairperson Quiz Committee POGS, Treasurer ISOPA Patna Chapter. She is the past Joint Secretary of ISOPA Patna Chapter and Jagdishri Marisha Award publication in National Journal. She has got special interest in high-risk pregnancy and preventive oncology. So welcome, Dr. Vinita. Dr. Sangam Jha, she is Associate Professor of AIIMS Patna. Publications, she has got many in national and international journal, published chapter in Das Gupta's Recent Advances. So, and then she has got also presented paper in National Conference, UFOXY, Nikon 19, RCOG 19, East Zone, RCOG, and many more. She has been received Dr. Nirmala Saxena Award for Best Poster on Official Theme in Boxcon 2022. She is the Master Trainer of GTM and Safe OR programs, a life member of Foxy, teaching experience. She has got more than 14 years and a very wonderful person. So with these words, I welcome all the panelists and over to the moderators now.
Thank you, Supriya. Thank you so much. And before we start, a very, very good evening to all the organizers and the panelists and the experts, Dr. Rekha, Dr. Sneha, everybody, very good evening. But before I begin, I would really want to tell one thing, one comment I have to make. Am I audible, Supriya?
Yes,
yes. One comment I want to make, like, you know, Dr. Patel ka talk was too good. Like it was like a magician, you know, he's speaking and we are just listening. And it was too good, amazing. Thank you, Dr. Patel. Thank you so much.
Thank you, madam.
Now, so before, without wasting time now, let us begin with the panel. So the topic, troubleshooting in amniotic fluid abnormalities. Now, Monica, can we have the next slide?
Yes.
Next one. Next. Okay, so already a lot of discussion has been done about this amniotic fluid. So again, just a repetition that amniotic fluid, the amount of amniotic fluid at any particular gestational age is actually fixed and it is within certain range and it is maintained by a dynamic equilibrium. So it is produced and at the same time it is absorbed so that a reasonable range of amniotic fluid is maintained at a particular gestation. Next one. Next one.
It's stuck. Ma'am, 1 minute. It's not moving from here.
Just click in between the slide. Just click for once and try to move.
Okay. Okay. Yeah.
So what are the functions of the amniotic fluid? Basically, amniotic fluid, there was one more slide, no? It skipped. Previous one.
That's same.
Okay, doesn't matter. So it protects, it is basically a shock absorber. It prevents compression of the umbilical cord. It maintains constant fetal body temperature. And yes, once the fetal ingests the amniotic fluid, it helps in GI maturation and it helps in the maturation of the lungs as well. And of course, it helps in the musculoskeletal development as it gives fetus the space to move around. And of course, it has got antibacterial properties also. Nutritive value, we don't know. It's a debatable issue, maybe or maybe not. And of course, hydrostatic wedge attacks during labor. So next one. So this amniotic fluid is basically 98% water, and the different sources of amniotic fluid already I think Raki has mentioned. Just a revision: transmembranous, intramembranous, and transcutaneous, fetal urine, and of course lung, the fluid from the lung. So these are the 5 important sources: transmembranous through the amnion, intramembranous flow via the fetal vessels, and transcutaneous via the fetal skin, fetal urine, as we have learned already. Next one. So this slide basically came as Raki. So we know this slide, maximum amniotic fluid volume is around 36 weeks. Before and after it decreases. So next one. Now this is the case actually. So this is the first case. 35-year-old Primi Gravida at 31 weeks of gestation came for routine checkup in the OPD. She had conceived via IVF. Till now her pregnancy was uneventful. She had received 2 doses of betnisol. However, her last ultrasound revealed AFI was 7. Her BMI was slightly higher side of the normal, 30.4. Her OGTT was normal. Blood pressure was normal. Fetal movements were perceived normally. So my question for Dr. What is oligohydramnios? Now this question is for, can I have the name of the panelist?
Dr. Ranjana Jha.
It's written.
Dr. Ranjana Jha. What is oligohydramnios?
Good evening, everyone. First of all, I thank the organizers and special thanks to Dr. MC Patel sir for giving me this opportunity. Now, what is oligohydramnios? When we were a student, that time we were told that when amniotic fluid level is 200 ml less at term, this is oligohydramnios. But nowadays, we measure, we do ultrasound for diagnosing oligohydramnios. As told by Raki, that when amniotic fluid, either we measure single vertical pocket or we measure amniotic fluid index. What is single largest vertical pocket? We measure single vertical pocket in amniotic fluid where there is no cord or fetal parts, and if it is less than or equal to 2, then this is called oligohydramnios. And what is either we can measure single vertical pocket or we can measure single vertical pocket in all 4 quadrants, and sum of if it is sum of more than less than 5 or equal to 5, then it is oligohydramnios. There are 2 methods. Either we can measure single vertical pocket or we can measure amniotic fluid index.
Very, very correctly said, Dr. Ranjana. This was correct. So we can come to the next slide now. Which is better measure for lighter volume, either AFI or the single deepest pocket? Dr. Lata?
Yes, ma'am. Good evening, madam.
Good evening.
See, we have got a variety of techniques which have been developed to assess AFP. But the 2 predominant approaches which are used is one, the measurement by AFI index, and the other is the single vertical pocket. That is the largest one. So you know AFI, how it is measured? The previous speakers have told it is the measurement of the deepest cord-free amniotic fluid pocket in each 4 quadrants of the maternal abdomen. And the single vertical pocket, it is the measurement of the maximum amniotic fluid in one segment. So this measurement of the single vertical pocket gives a better option. It does not cause overdiagnose the oligohydramnios. And then there is no intra-observed error is less in this. So measurement of single vertical pocket is desirable.
Yes, yes, very correctly said, Dr. Lata. Actually, the thing is this, that when we are calculating this AFI, so the inter-observer error is of 2 centimeters and intra also is of 1 centimeter. So this is not the better option. The better option is single deepest pocket, and because the error is less and also because it does not cause overdiagnosis of oligohydramnios, as Pragya had mentioned. So next, Monica. What can be the causes of oligohydramnios? Now this question is for Dr. Charu.
Yes, ma'am. Thank you, ma'am. Before I start, let me do my duty by thanking MC Patel, sir, and our society, and of course the 2 wonderful moderators, Dr. Jyoti and Dr. Monica. Now coming to the question, oligohydramnios can be due to various causes. It can be either due to premature rupture of membranes, which is very preterm, or certain maternal conditions are associated with it, like chronic hypertension, vascular diseases in the mother, then coagulopathies can be there, thrombophilia in the mother can give rise to oligohydramnios, especially if she's taking all those drugs. Then any condition giving rise to uteroplacental insufficiency and placental abnormalities can also be the cause of oligohydramnios. Certain infections like syphilis, cytomegalovirus infections, then parvovirus infection can also lead to oligohydramnios. Any obstructive conditions of the fetus or congenital malformations like chromosomal abnormalities or structural abnormalities of the fetus will also result in oligohydramnios. And one very important thing in the history is we have to take history of any medication by the antenatal mother. Like if she's on any drug like ACE inhibitors or prostaglandin synthetase inhibitors like NSAIDs or any other medical history, we have to take into account because it can also lead to oligohydramnios.
Thank you, Charu. Thank you so much. Very well covered and explained. Now, I would just like to add one thing, that these drugs like ACE inhibitors and angiotensin receptor enzyme blockers, what they actually do is that they cause this fetal, they cause hypotension in the fetus. And because of this, what happens is renal ischemia. And therefore, the amount of urine is decreased. This way, they can cause oligohydramnios. And of course, NSAID is also almost similar. They cause vasoconstriction of the renal arteriole and the PCT also. So it suffers anemia, and therefore the GFR decreases and the urine decreases. So hence oligo. So next slide, please. Now, what are the conditions associated with oligohydramnios? Can Shraddha answer?
Good evening, madams.
Good evening.
So my patient, this is an IVF pregnancy at 31 weeks and the AFI is 7. She is now diagnosed with oligohydramnios. Now we have to do a detailed survey, look at the history, detailed survey, what could be the cause of oligohydramnios in this patient, and we have to keep our mind open also. So the causes could be maternal, it could be fetal, it could be placental. So we have to exclude the genetic causes, that is the chromosomal abnormalities that could cause oligohydramnios. If there is any associated congenital anomaly like cleft lip, palate, esophageal atresia, any problem with the kidneys, duodenal atresia, that we have to look during the ultrasound survey. We have to think of other causes of IUGR. It could be because of fetal demise, or it could be because of post-dated pregnancy. And also ruptured membrane can be the cause of oligohydramnios.
Esophageal atresia
will cause poly.
Yeah, that because poly.
Yes. Then we have to look at the maternal cause. What could be the cause? It could be because of maternal hypertension. It could be because of preeclampsia, diabetes. Then APLA, IVF pregnancies in them, APLA is quite common. That we have to also think of, keep that in the mind. We have to take the history, what medicine, if any medicines he has been taking, any AC inhibitors he have been taking, or prostaglandin synthetase inhibitor. And then other causes, it could be because of abruption. If it is a twin pregnancy, we should think of twin-to-twin transfusion syndrome.
Yes, thank you, Shraddha. So you've mentioned almost all the causes, fetal, maternal, and placental, and drugs, and we should not forget idiopathic. So next slide. Now, what congenital malformations can actually lead to oligohydramnios? Can Dr. Sangam Jha take up this question?
Good evening, ma'am, and Dr. Monica. So before answering this question, I would like to thank MC Patel sir and the
Dr. Sangam?
Your voice is not clear.
She is not there?
Yeah, she is there, but voice is not clear.
Okay.
Dr. Sangam, please be loud.
Unmute तो नहीं करना है. Can she hear us?
Yes, ma'am, वो है, but उनका voice नहीं आ रहा. Ma'am.
Okay, so next panelist can take this.
Congenital malformations leading to oligohydramnias are mostly renal abnormalities like dysplastic kidneys, bilateral or unilateral dysplastic kidneys, and then polycystic kidney disease, then other renal abnormalities like posterior urethral valve, sirenomelia, urethral atresia, persistent cloaca. And from 18 weeks only, urine formation is the main source of amniotic fluid. So the prognosis is very poor if it's before 18 weeks.
Okay, correctly said. And thank you, Dr. Vinita. Now, is Dr. Sangam Jha hai kya? Has she come?
And she is there. Her
audio.
Okay. Dr. Sangam can put off her video and just come on audio. That way she can join.
Try kar lo. Because still another half an hour, 40 minutes it will take. So should we proceed?
Yes, ma'am.
Okay, so Dr. Vinita, you can take this one also. How to counsel and manage this patient?
Now it is only 31 weeks and the AFI is 7. So it's a borderline oligohydramnia.
Yes.
And at this stage, there is so much risk of IUGR and uteroplacental insufficiency. So we have to counsel the patients about early delivery, the risks of premature delivery versus the in utero death or in utero risks. And we have to see a whole anatomy, a detailed targeted anatomy and congenital anomaly scan. We have to rule out, we have to counsel the patient about the expectant management, the need for continuous fetal surveillance during the expectant management, the weekly color Doppler studies of umbilical artery, the routine NST and BPP, and biophysical profile, also to look for amniotic fluid volume and about the fetal growth in the successive scans. We have to see, and we have to counsel about proper hydration and keep the patient under strict surveillance.
Yes, I think you have covered most of the thing. Basically, what she is IVF pregnancy, she is at 31 weeks and she is scared because of this AFI problem. So the only thing is proper counseling that, okay, 90% things will go all right, but you need to be under proper surveillance, close monitoring. You should get a repeat scan done, take care of her hydration, give her IV if she's not taking orally, and of course, follow her up with weekly NST test. Her blood pressure, sugar should be monitored frequently. And fetal movements, yes, of course, they are very, very important. So anomalies can are all already done only. All was normal. So we can follow her up. Definitely, we can follow her up with all this counseling and investigations. So next slide. What complications are expected in oligohydramnios? Dr. Ranjana Jha.
Yes, ma'am. Complications can occur during antenatal time also or intrapartum also. During antenatal time, there is increased chance of fetal distress, cord collapse, malpresentation, cord compression. There is variable deceleration also. And during antepartum period, there is increased chance of fetal distress. There is increased operative delivery, increased chance of IUD also, stillbirth also. There is increased chance of instrumental delivery also during intrapartum time. And sometimes there is prolonged labor also. And to the fetus, there are so many problems due to decreased lichens. There is constriction of the extremities. There is one syndrome called Potter syndrome, which occurs to the fetus, in which there is a prominent epicanthal fold, broad nose, pulmonary hypoplasia, which leads to respiratory failure. And there are so many skeletal deformities and neuromuscular deformities also. And due to increased amniotic band, there is constricture of the extremities. Then there is increased chance of fetal distress, leading to intrauterine fetal death also. These are the complications of the fetus.
All right. Thank you so much. You have correctly, summarized everything. Basically, 4 or 5 important complications. One is fetal distress. It can be because of anything, because of cord accidents, because of cord compression. Another important complication is abruption. So it can happen anytime. It is very, very common in oligohydramnios and chorioamnionitis. It was missed over here. I think chorioamnionitis is an important complication if the liquor is less because of PPROM. So these and others you have mentioned correctly. So now next question is, what is borderline oligohydramnios for Dr. Lata Gupta?
We know oligohydramnios is when the AFI index is less than 5. And when the AFI index, it measures between 5 to 8, then we can call it as a borderline oligohydramnios. There are no consequences that the patient should be delivered immediately in such cases. The management depends on the case. We have to monitor these patients properly.
Right. Thank you, Dr. Lata. Yes, so borderline oligohydramnios is AFI between 5 to 8 somewhere, like in this particular patient. And the management, it is not necessary that you just have to go and proceed and deliver. Even if the pregnancy is 34 weeks, 35 weeks, there is no consensus that yes, we have to deliver. That like maturity ho gaya hai, abhi delivery karna. No, it has to be managed case-wise. Number of other morbidities have to be taken into account, and then only the decision can be made. Now, this last, what is this question? What is CAOS? This is for Charu.
CAOS stands basically for chronic abruptio oligohydramnios sequence, which is a rare clinical condition and presence due to prolonged lasting vaginal bleeding in absence of placenta previa and other identifiable causes of bleeding per vaginum.
Correct.
And it is associated with oligohydramnios because of chronic placental insufficiency. Most of the times preterm delivery occurs in this case, and fetal lung is affected. And we can see fetal growth restrictions, small for dead babies, and sometimes features of chorioamnionitis also develops.
So correctly said, Dr. Charu, and much depends upon the gestational age at which this chronic abruption and oligo has happened. And if it occurs less than 24 weeks, then pulmonary hypoplasia also is a risk factor. So next slide. This patient received amino acid infusion 3 units. Repeat scan was done after 10 days. Her AFI was found to be 11 this time. Dopplers were normal, her CPR, all the various parameters, umbilical and MCA were normal. BPD-AC disparity was found. BPD corresponded to 32 weeks and AC to 29 weeks. Her expected weight was found to be 1800 grams. Now, what is the further management? What should be the next step?
Yes.
Shraddha?
So this patient once diagnosed with oligohydramnios and
Shraddha, not clear, Shraddha.
Am I audible now?
Yes, yes.
So this patient, once diagnosed with oligohydramnios, and she received amino acid, and now her AFI is 11, but she is just 32 weeks. So we need to manage this patient so that we can delay the duration of this pregnancy so that we can deliver a healthy baby. This patient needs close monitoring.
Yes.
Betnisol has been given, that is very good. So close monitoring will be with color Doppler. We will do twice week color Doppler every 2 weeks, and and also the other parameters. The biometry will also be done, and that will be plotted in the growth chart. And according to the findings of the color Doppler, we will manage. If the color Doppler is normal, we will follow her every 2 weekly. But if at any stage it becomes like decreased, if the findings of the color Doppler decreases, then we have to do more close monitoring every, that is twice a week. But if it becomes absent or reverse flow, we have to deliver it. And we have to look at other parameters also. But if everything falls in place, then we can deliver her at 37 weeks in a consultant-led unit, and this would be followed in the consultant-led unit where there is a facility. If at any time any abnormality takes place, this would be followed in a hospital where there is a facility for neonatology also.
Correctly said, Dr. Shraddha. So now the follow-up with ultrasound, as you said, it was done with color Doppler after 2 weeks. Patient was advised for fetal movements monitoring and to report SOS, and repeat scan at 35 weeks revealed that AFI was again slightly less. It was borderline. Again, it was around 9. BPD acid disparity was persistent. However, fetus continued to gain weight, and fetal weight was 2.5 kg. So what is the further management plan for this patient? Vinita? Dr. Vinita?
Now we have been doing color Doppler and the reports are normal. And I can see that except from the disparity in BPD and abdominal circumference, the AFI is also 9. And the fetus is also gaining weight. So we can take this advantage to continue the pregnancy for a few more weeks so that it reaches the term. We can take it to term to 37 weeks.
Yes, correct.
And
So
then deliver.
Yes. Thank you, Vinita. So this patient was actually delivered by elective LSCS at 37 weeks. Baby weight was 2.5 kg and the outcome was okay. Both mother and baby did well. So thank you. I request now Dr. Monica to take up the next case.
Thank you, ma'am. First of all, I would like to thank Dr. MC Patel, sir, for giving us this opportunity, and Supriya ma'am and Brita ma'am for handing us this important task of handling the panel discussion. So we quickly move on to the second case. Am I audible? If anyone can confirm? Okay.
Yes, ma'am.
Thank you. So we go to the second case. First, Gravida 1, para 0. She presented for antenatal checkup at 26 weeks with a history of abdominal distension, heaviness, and lesser perception of fetal movement for the last 1 week. Although she had been a regular follow-up in our antenatal clinic, and all her previous investigations were in the normal range. She was a booked case. On examination, there was no pallor, no edema, BP was in the normal range. The uterus we found to be of 32-week size. The fetal lie could not be asserted because it was variable. I could not get the head or the breech anywhere. The FHS was also heard, but it was heard very faintly. So what can be the possible diagnosis of this condition? If I can ask Dr. Sangam to answer, please.
I am audible?
Yeah, you are.
Okay.
Hello.
So she is with a 26-week gestational age and now came with the complaint of abdominal distension. On examination, her uterus is 32 weeks size. So it is large for gestational age. Then second, her fetal parts are not very well palpable. Okay, that indicates
Your voice is getting disconnected. Dr. Sangam, can you try some other distinct device? Hello.
Hello. Sorry.
Yeah, you.
Actually, yes.
Okay.
I can
Okay,
hear,
let's.
but there's some network issue at my place, so it's a.
Okay, just
getting
try
interrupted.
once, otherwise we'll move forward. See if it.
Am I audible?
You are, but the like voice is coming very late, I think. There is a lag between.
Yeah, it's a.
So we'll move forward. You try and rectify the network issue. So we'll move forward with the question. So the possible causes of this presentation can be most likely a polyhydramnios. It can be a big baby, but mostly in big babies, we do get the fetal parts easily and FHS is quite nicely hurt. In multiple pregnancies, we get different fetal parts, many fetal parts are there. In abruption, tenderness, and a little bit of vaginal bleeding can be there. So these are the causes maybe because of which the patient presented at this gestational age with an increased or large for dates. These are the other differential diagnoses which we might have to consider in this case. But on examination, like how do we proceed for diagnosis then? If we can ask Ranjana ma'am, Dr. Ranjana Jha ma'am.
Yes, ma'am. We have to do some workup in this case. So we will do some investigation, such as we will do blood grouping, RH tapping to the mother, and we will also screen for diabetes. Then torch infection. Yeah.
Other examination findings you would like to add? Usual findings that we get on seeing a patient of polyhydramnios.
The patient is abdominal size, the girth of the abdomen is more than the period of amenorrhea. There is fetal palpation is less, then skin is very shiny, and there is also pedal edema, vulval edema. Patient complains of difficulty in taking respiration. These are the complaints by the patient.
Yes,
so when we examine the patient, the height of fundus is more than the period of amenorrhea, and very fetal heart sounds are felt with very difficulty, and presentations are not also felt well. There is malpresentation also, and the heart sounds are very muffled, not felt well.
Yes,
and
how will we confirm then?
Confirmation is by ultrasonography. We will do ultrasonography. For mother, we will do also diabetes screening because sometimes and also blood grouping because RH isoimmunization or hydrospitalis is also a common cause of hydramnios.
Okay, ma'am. So we stick to the ultrasound right now. We have done an ultrasound.
As told by Dr. Rakhi ma'am, it will be we will measure a single largest vertical pocket if it is, and we will also do AFI. Because if FI is more than 24, then it is diagnostic of hydramnios. And single vertical pocket, if it is more than 8, then it is also diagnostic of. And we can, we will also find in ultrasound any malformation of the fetus, such as duodenal atresia, esophageal atresia.
Yes, ma'am, we'll come to that. First, let's discuss the report of the patient. Thank you, ma'am. Yes, ma'am. Thank you for giving us the clinical picture and the ultrasound diagnosis for a case of polyhydramnios. So for this patient, we did an ultrasound and found that it reported a single live fetus of 780 grams with a variable lie. Placenta was normal, anterior at fundus, and the liquor was found to be increased both subjectively and also by the measurement of AFI. It came out to be 29 centimeters. So this is frankly a case of polyhydramnios where there is excessive volume of fluid, and as rightly pointed out by Ranjana ma'am, that AFI should be more than 24 or 25 and SDP 8 centimeters. So next we move on to any other information which we would like our radiologists and ultrasonologists to report. Apart from that, there is an increased liquor and that the baby is this weight and placenta is here. These are the three main points that were given. But would you like any extra information that the ultrasonologist should provide? If I can put this question to Lata ma'am, Dr. Lata Gupta ma'am.
Yes. Whenever there is polyhydramnios, definitely I want my sonologist, ultrasonologist to give me more information regarding the fetal growth. I want to know whether it is a macrosomic or a normal bed baby. Is there any abnormality with the fetal cardiac anatomy? I want to know in detail about the placenta, any presence of chorioangiomas. Then also the fetal movements are whether they are proper to assess the neurological functions. Then sometimes I would like to know the position of the fetal hands, feet to rule out some rare syndromes, which like arthrogryposis syndromes, it is a muscular disease. Then the one important thing is the presence of the stomach bubble, which gives clue to the presence of any gastro-alimentary tract malformations like tracheoesophageal fistulas, esophageal and the anatomy of the face, the palate, the cleft lip. I want a detailed examination of this, and then any obstructing mass in the neck portion, and important is the fetal kidneys. Whether both the kidneys are present or no, and when there is any uretropelvic junction obstruction which can lead to hydramnios. And about the lower spine and pelvis for the evidence of sacrococcygeal teratoma. I'll be really worried about any the malformations if the baby is having. So I expect the sonologist to mention about all this in detail.
Thank you, ma'am. So very nicely put that all these features should be addressed by the sonologist. They should be careful while reporting any case of polyhydramnios with all the congenital anomalies that can be causing this condition. So especially looking at the gastrointestinal part, maybe sometimes it may not develop at that 26 weeks of gestation and is not visible, but repeated ultrasounds may lead to detection. It is also said that many of the anomalies may be detected even after birth. So ultrasound may not be able to detect all the anomalies, but at least the anomalies which most commonly cause polyhydramnios should be ruled out. So for this patient also, a detailed ultrasound was repeated. We asked for a very detailed ultrasound report of the baby, and that reported no fetal anomalies, no obvious fetal anomalies were there. The placenta was also normal. There was no chorioangioma. And chorioangioma also, which is more than 5 centimeters, is said to be causing polyhydramnios. Lesser ones, smaller ones, they are not very much causing increased liquor. So for this, any other investigations we would like to do after a detailed ultrasound has been done and all anomalies have been ruled out? Dr. Charu, ma'am can answer, please.
Yes, Dr. Monica, after this detailed ultrasound scan where we see all the things appearing normal to us, including the maternal and fetal aspect, then we would certainly like to undergo certain investigations on maternal part. First of all, the most common is the glucose tolerance test, or what we call is that GTT, can lead to polyhydramnios because of macrosomia, if at all it is there. Then certain viral infections are common in mother, which can ultimately give rise to polyhydramnios. Go for torch infection testing and virus infection.
Everybody else can please put your mics on mute because we are getting a lot of disturbance.
Yeah. So let me continue. We can have invasive testing also in the form of karyotyping or microarray assay if we see any features of intrauterine fetal growth restriction. But what we come out with the ultrasound report as everything to be normal as far as fetus is also concerned. Then we can have DNA testing. But this case seems to be a case of isolated polyhydramnios, which can be due to maternal diabetes or can be due to aluminization or any congenital infections.
Yes, thank you, ma'am. Very well covered. So even if a glucose tolerance has been done beforehand, usually we do it at the first visit in Indian population. Even then, we need to consider doing it again. If we find that there is polyhydramnios, that will help us in detecting the cause. And if it has been done a month earlier also, then you can repeat the diabetes screen, which has been suggested or recommended by the Society of Maternal and Fetal Medicine. So we should know that if the baby is found to be normal on an ultrasound, which is a structurally normal fetus, these are the three main conditions which can cause polyhydramnios. One is maternal diabetes, like ma'am said, it has to be done, OGTT, aluminization, for which investigations like HPLC and testing for the other isoimmunization syndromes, and congenital infections. Some markers we can get on the ultrasound also of the congenital infections, but testing TORCH with parvovirus and syphilis, which is important if we find polyhydramnios with a normal fetus. So for this patient, the reports came to be normal. OGTT was normal. Infection screen was also normal. So we come to the diagnosis of idiopathic polyhydramnios, and we know that this is a diagnosis of exclusion. So what can be the etiopathogenesis? How is polyhydramnios formed? This is a theoretical question, but it will help us understand the basis behind the polyhydramnios. If Dr. Shraddha can take up this question.
Yes. So actually polyhydramnios in 60% of the cases, it is idiopathic. We cannot find the cause. But once it has been diagnosed, we have to do the thorough screening for the fetus, for the mother, and for the baby. In the fetus, we have to look for any factor which is leading to defective swallowing, defective absorption, or if there is increased urine production because of any renal pathology or GI pathology or cleft lip, anything like that. In the mother also, we have to screen what are the if she has any condition which can lead to polyhydramnios of the baby. We have to screen her for diabetes. We have to we have to screen for chronic kidney disease in the mother, and also in the placenta we have to look for if there is chorioangioma, which can lead to polyhydramnios. And if once these are excluded, it would be labeled as idiopathic. But we have to do a complete survey before labeling it like that.
Yes, thank you. So we know now that most of the causes are idiopathic, but other fetal, maternal, and placental causes should be ruled out. So what are the complications which can be associated with the polyhydramnios? Why do we fear polyhydramnios so much, Dr. Sangam?
So am I audible now?
Yes.
Yeah. Am I audible?
Yes, you are.
Okay. So the complications which are associated with polyhydramnios most commonly is the maternal presence with the abdominal distension. So she can complain with the abdominal tightness, pain in the abdomen, and that enlarged abdomen can press on the diaphragmatic movement. So that interference will lead to shortness of breath, or if it's over distended, she can present with the pre-labor rupture of membrane. She can go into preterm labor. So sometimes a mirrored syndrome can also appear where there is a fetal hydrops and the placenta-megaly with the maternal edema. She can sometimes present with the lower limb swelling also, and sometimes vulval swelling also. And during labor, there is an increased risk of malpresentation, then increased risk of dysfunctional labor, then increased operative deliveries, and then placental abruption can occur. And after delivery, she can go into PPH, and there is always increased risk of amniotic fluid embolism in such cases. In fetal and neonatal, due to the chromosomal anomaly or the macrosomia, so perinatal mortality rate increases up to 2-fold than the general population. Risk of cord collapse is also high. And in such neonates, the TTN risk also increases, and due to macrosomia, neonatal hypoglycemia can occur. So all this lead to increased perinatal morbidity.
Yes, very rightly said. So fetal macrosomia can occur even if the mother is non-diabetic in cases of polyhydramnios, it has been seen. So 30-40% of the babies will be born as a macrosomia, even if the OGTT comes out to be normal, like it's in the normal range. So should all polyhydramnios be treated? Once we see polyhydramnios, should we rush to give some medication or do some procedure? Should all of the polyhydramnios be diagnosed, be treated? Dr. Vinita, please.
No, actually polyhydramnios is only treated if the mother is in distress. If the mother presents with respiratory distress, then only it's treated. And the idiopathic ones are not treated initially because they are mostly mild and do not require treatment.
Okay, very rightly said that only if the mother is having severe respiratory distress, significant discomfort, or she is undergoing preterm labor, then maybe we need to act. And if we diagnose a case as a mild polyhydramnios and idiopathic one, then usually it does not require treatment. And we know that mild is most of the cases, that 80% of all the hydramnios cases are mild. This also, our case is also a mild polyhydramnios. And can you comment, Dr. Vinita, on other therapies that are there for polyhydramnios?
Actually, yeah, well, first, if we are talking about the mother, then we can do amnio reduction. And there are drugs also, but there is controversy about the drugs like indomethacin and sulindac. So there are so much controversies that they will cause constriction of ductus arteriosus. And if there is a raised blood sugar, then we treat that. We keep a good glycemic control. If there is any congenital anomaly which is not treatable, then we have to terminate, or which is not compatible with life, then we have to terminate the pregnancy or counsel. And we can also send it to fetal medicine specialists for further treatment, like arrhythmias or hydrops, which require blood transfusion, or thoracoamniotic shunting, etc. For laser occlusion, we send to fetal medicine specialists for treatment.
Yes, very correctly pointed out. For these specialized treatments, we should refer these patients to specialized people who are practicing fetal medicine. And any polyhydramnios developing due to hydrops needs treatment if they are dysarrhythmic or having fetal anemia. Good control of diabetes is a very important step. There are few medications which were used earlier. Indomethacin was one of them, which is a PG synthetase inhibitor. And usually it is used before 32 weeks because after that it leads to more complications like PDA constriction or low birth weight and internal perforation. So now it is recommended that indomethacin should not be used alone for the sole purpose of decreasing amniotic fluid. If there is no distress or if it is mild idiopathic polyhydramnios, then it should not be used. But this patient was put up on indomethacin. She had delivered almost 8 years ago with us, and indomethacin 25 milligram was used for her TDS for a period of 2 to 3 weeks, and AFI was followed, and it gradually came down. It was stopped before 30 weeks of gestation. So any other treatment options are there, Anjana ma'am?
Yes, if patient is symptomatic or there is severe polyhydramnios, then therapeutic amniocentesis, which is known as amino reduction, that can be done.
Okay. So we are not going into the details, but yes, if there are severe symptoms and the patient is in very much distress, then serial amnio reductions can be done, and the procedure is outlined. The complications can be rupture of membrane, preterm labor, abruption, and infection. So currently, in current recommendations, indomethacin is recommended only during this procedure because it will have two functions. One, it will simultaneously reduce the production of urine, and two, it will act as a tocolytic. So both functions will be there. So if indomethacin is to be used, it is used only during 48 hours of this amnio reduction phase, not for a prolonged time. So there is an acute hydramnios. We'll leave it to the next case. So any conservative methods are of use? Lata ma'am, do you know of any conservative methods which can be used for treating polyhydramnios?
We can advise some bed rest, restriction of fluids and salt, and also advise some diuretics. But these conservative methods are usually not
very effective.
Again, we have to go for amino reduction.
Yeah. Okay. So these are not effective, so not recommended by any of the societies. Is there a need to repeat the ultrasound and monitor for the fetus? Dr. Charu ma'am, please.
the role of ultrasound, monitoring by ultrasound is really questionable, but however, we have to monitor the progression of the disease or the severity of polyhydramnios by serial ultrasound monitoring only, because we have to measure the AFI, the pockets measurement will be there. Then as regards the fetal surveillance, we have to use ultrasound to monitor the proper growth and progression of fetus according to gestation age. There lies the opinion and importance of ultrasound monitoring. But for sole indication, I don't think it's needed for polyhydramnios.
We now know that mild and idiopathic polyhydramnios, they do not increase the neonatal risks much, the fetal risks much. So it is not recommended. But if the fetus is at risk for IUGR or fetal growth restriction, then usually we resort to antepartum fetal surveillance, as ma'am rightly pointed out. So how do we plan for delivery, Dr. Shraddha, in such a case? So now my patient is now around 34, 35 weeks of gestation, and her Leica has come to be normal, like in the normal range. It is around 18, 17, something of that range, which is less than 24. So how do we plan for delivery?
So if the Leica has come back to normal, then we should monitor her closely, look for the symptoms, and if she is asymptomatic, we should allow her for spontaneous onset of labor. These patients can go in preterm labor and prom, but we need to monitor her. She should be in close contact with her gynecologist. Labor induction should be done only after 39 weeks, not before that. And once she is in labor, we need to monitor her closely, because there is a risk of cord prolapse. CTG monitoring may be required, and the mode of delivery will depend on whether we can allow her vaginal delivery or a cesarean. That would depend on the obstetric indication at that time.
Yes, thank you. So that will depend on the presentation, because we know that polyhydramnios can present with any abnormal presentation, malpresentation. So we will decide according to that. Gestational age is normal, like it should be at spontaneous onset of labor, or induction will not be allowed below 39 weeks of gestation.
We have to follow the usual guidelines for induction.
Usual guidelines, yes. So for the intrapartum management, there are some precautions that we need to take, especially for this patient, which has having large amount of Leica also. Like even if the Leica has come back to be normal, it's still on the higher side. And those cases where the Leica is seriously high, like if it is say 30 or 35, then what precaution should we take, Dr. Sangam? Dr. Sangam is there?
So intrapartum, they should actually, with the higher amount of Leica volume. Yes, I am audible. Am I audible?
Yeah, you are.
Yes. Okay. So during labor, when the patient come in the labor, then first we should ascertain the lie, as the chances of malpresentation will be high. So first we should confirm the lie by doing an ultrasound. Then patient should not be allowed to move around a lot, because that will increase the chance of rupture of membrane and subsequently cord prolapse. During the labor, the heart sound should be monitored continuously if the facility is available. Then after the rupture of membrane, one should do a PV examination, then reassure that there is no cord prolapse, and the gradual release of amniotic fluid by doing a low and controlled amniotomy is preferred. That will stabilize the head or presenting part. And the active management of labor should be done, active management of third stage of labor should be done, as the risk of PPH is high in such cases.
Yeah, very rightly said. So usually in our labor room also, we use the ultrasound to detect the lie and the presentation if it is not very clear on the per abdomen examination, and a slow controlled amniotomy is the key to the correct management that will prevent cord prolapse, that will prevent abruption, that will prevent hand prolapse, all of these complications. Thank you, Dr. Sangam. So just to report the case that we had, the baby was born a low birth weight of 2.4 kg. by 38 weeks by spontaneous onset of labor. And we know that most studies also report that there is no increase in rates of stillbirth or neonatal death, which is associated with idiopathic polyhydramnios, which was this case, mild idiopathic polyhydramnios. And for this same patient, I delivered a normal delivery 4 years after the first delivery. And in that case, there was no recurrence, like there was no polyhydramnios. And the recurrence risk has been seen that there is no increased risk for idiopathic ones, but will depend on the cause. If there is associated maternal or fetal conditions, then it might recur, but it does not usually recur for an idiopathic cause. So with this, we move on to the third case quickly, and I request Jyoti ma'am to please conduct the third case.
Thank you, Monica. Now this third case, am I audible and visible? I don't know.
Yes, ma'am. Yes, ma'am.
Okay, this is the third case. So this is a Gravida 3 para 2+0 with previous 2 full-term normal deliveries. Both babies alive and well, presented at 34 weeks gestation with history of leaking fluid per vaginum few hours back. And on examination, the fundal height corresponded to 34 weeks and presentation was cephalic. So question is, how to identify and confirm that patient has PPROM? Preterm premature of membranes. So this question is for Dr. Vinita. How to identify?
For identification of PPROM, the first requirement is a sterile vaginal speculum, and a pool of fluid in the vagina is very much suggestive of amniotic fluid or PPROM. Next, we can also do insulin-like growth factor binding protein and placental alpha microglobulin. These two are highly suggestive of amniotic fluid in the vagina. We can also do nitrazine paper testing, and when it turns blue, it suggests ruptured membranes. And vaginal manipulation and per vaginal examination and using fetal probes, etc., should be avoided. And ultrasound's role is controversial in this.
Thank you, Vinita.
As far as I know.
Yes, it is okay. Whatever you have said, it's perfectly right. History is the main thing. So usually patient give history, but sometimes the history is not very much specific. So sometimes they say that thoda bahut leak hua, and they are not very specific. They confuse discharge with this. So have to do a sterile speculum examination. Digital PV in preterm patients, that has to be avoided as far as possible. Testing, yes, there are so many tests, pH testing with nitrazine paper and others, as you have mentioned. Ultrasound is a thing which may be used to confirm whether the amount of LICAR has decreased or not. And if it has decreased along with the history, along with the speculum, that is the that adds to the diagnosis of PPROM. So next question is, next one. Would you like to hospitalize this patient with PPROM? Dr. Ranjana Jha.
Yes, ma'am. Yes, ma'am. I would like to hospitalize. Definitely, I would like to hospitalize this patient.
Yes, correct. Why?
After hospitalizing this patient, I will ask her to apply sanitary pad. I will give her antibiotics. If pregnancy is less than 34 weeks, then I will prescribe her corticosteroids. And if it is less than 32 weeks, then I will also prescribe her Maxer for neuroprotection. For this, and it has been seen that majority of the patient goes into labor. So I would like to hospitalize this patient.
Thank you. I think correctly said that yes, we should always try to hospitalize the patient because there are chances of mishaps. There are chances of cord accidents. There are chances of poliomyelitis. There is so many things can happen to such patients. So yes, important is admission for investigation and at least 48 hours for the steroid coverage and for investigating this patient. And mostly these patients usually go into labor within 1 week. Very, very rarely the latency period is more. And this latency period is actually inversely proportional to the gestational age. So more the gestational age, lesser is the latency period. Now, what are the risks involved in PPROM? Dr. Lata?
The risk with the PPROM is really nightmare to us obstetricians.
Yes.
Is they can have abruptio, cord accidents can occur like cord compression and prolapse, fetal distress, intrauterine death, and preterm delivery. And managing these babies is another headache. So we can categorize into the maternal complications and the fetal complications. Here, both of them are under risk. The maternal complication, they can have chorioamnionitis, which is a dead complication, placental abruption, retained placenta, again leading to PPH, puerperal endometritis, sepsis. So the mortality is increased. In the fetal, again, the fetal infection can occur. There can be cord prolapse, hand prolapse, and then the preterm, these babies are preterm, so they can suffer from respiratory distress syndrome, intraventricular hemorrhage, necrotizing enterocolitis. And the long-term sequelae, these fetus can suffer are PVLM, cerebral palsy. They can suffer from hearing, visual abnormalities, mental retardation, and chronic lung diseases. So these are the complications with the PPROM.
Yes, correctly mentioned, Dr. Lata. You have almost covered everything. Maternal and fetal, both of them are at risk. And the thing is, kya karna hai, like when to deliver. The most important thing is when to deliver. How to prevent both the mother, how to protect both the mother and the fetus, and somewhere we have to draw a balance. So the thing is, how to manage. Now, Charu.
Yes, ma'am. Now, since we have admitted the patient for observation and for other tests, the first thing we would like to have is a baseline NST for this test. We can, what we call it as admission NST. And we'll ask for certain investigations like blood test for complete blood count and all to assess the science for any assessing any signs of infection. Then we would also like to have one high vaginal swab. It should be sent for culture and sensitivity. And according to the sensitivity report, we can institute antibiotics to this pregnant female. Then we have to monitor her baseline pulse, temperature, BP, because she can have signs and symptoms. She can show signs and symptoms of chorioamnionitis also. Then ultrasound is very, very important to confirm the
There's so much background voice noise is coming. I don't know. Hello?
Shall I start?
Yes.
Then we can also advise her one baseline ultrasound at this stage to confirm the presentation slide, then AFI, like a pocket, etc. And moreover, color Doppler should be advised for this thing to be more certain. Then we can always ask on rounds and then in our examination about the fetal movement by the perception by the mother. Then the steroid coverage should be given if it is less than 34 weeks, as rightly said by Dr. Ranjana. And below 32 weeks, we can also go for MEXELF coverage for neuroprotection. One very important thing, as Dr. MC Patel has just now elaborated and enumerated, we have to counsel the attendants also and tell them about the risk of this condition. And as far as this case is concerned, we have to be more of a masterly inactivity kind of a thing with conservative management of this patient.
So correctly said, Charu, the management has to be conservative, but at what time we have to interfere, at what time we can continue with the conservative management, all this has to be decided, and it depends basically on the maternal parameters of suspicion of chorioamnionitis and the fetal parameters of fetal distress. So anytime fetal distress, any fetal mishap, or anytime maternal chorioamnionitis feature is there, like, what are the features of chorioamnionitis? Like vaginal
fever, tachycardia, foul smelling discharge, pain abdomen.
Pain abdomen, foul smelling vaginal discharge. If CRP is raised, if the counts are raised, So all this, if all these are present, then definitely we have to think of termination of the pregnancy, and in any form like resection or whatever. And again, if fetal distress anytime, so you have to monitor by non-stress test, fetal movement starting, growth scans have to be done, and weekly amniotic fluid assessment also has to be done. So now for Shraddha, what is the any role of tocolysis in this patient with
In
PPRO?
PROM, there is no role of tocolysis. The only indication for tocolysis is for the steroid coverage. We want to buy the time so that the steroid cover can be done. And the other indication is that the patient can be, if suppose if she is in the periphery and she needs to be transferred to a center, tertiary center. So we have to give that time for in utero transfer. So these are the only indications.
Yes, only two indications. There's no role of tocolysis, no way, especially if chorioamnitis is there any problem. No role of neither prophylactic nor therapeutic. It serves no purpose, only for steroid coverage or transfer to the specialized unit where NICU facilities are there, because we know it is a preterm baby. So now PPRM is cervical cerclage. How to manage?
Ma'am, the dilemma. So dilemma is whether to remove the cerclage or not.
Yes.
So depending on the gestational age, if she is falling between the age of viability till 34 weeks, we can maximum delay up to 48 hours to facilitate the in utero transfer to the higher center if the patient is at periphery. So during that period, but the features of chorioamnitis should be absent in such cases. Otherwise, in presence of any signs of or symptoms of infection, it should be removed immediately. Less than age of viability, depending on the centers, like 26 or 24 or 28. If less than 26 or more than 34, there is no we do not get any added advantage in terms of the maternal or fetal outcome in prolonging or delaying the removal of suture. So in that case, it should.
Yes, correct. Dr. Sangam, you have correctly said that removing suture or not does not have any benefit after the viable age. But if the age is less, gestational age is less, then definitely the maximum we can put the suture is for 72 hours. Not beyond that, and that too, if there is no feature of chorioamnitis, no bleeding per vaginum, and the liquor is clear, not foul smelling, so all those rule out, no fetal distress, only then we can decide to continue with proper counseling to keep it for at least 72 hours max to max. So now question 7 for what to look for as signs and symptoms of clinical chorioamnitis. Dr. Vinita?
Now, fever is the single most important indicator for chorioamnionitis. Degrees centigrade fever, or if it is less than 39, means 38 to 38.9 degrees centigrade. Then one more risk factor like multiple pelvic examination or meconium stain like or low parity. Apart from this, lower abdominal pain, then foul smelling, discharge, then malaise, decreased fetal movement, maternal tachycardia, fetal tachycardia. All these are suggestive of chorioamnionitis, WBC count.
Yes, correct. So you very rightly said, and previously like it was that even subclinical chorioamnionitis, that is in the amniotic fluid culture if you are doing, then if there is infection, amniotic fluid infection, then also it was considered as indication for termination. But recent guidelines have said that not subclinical, because subclinical it is very, very difficult to monitor. To take the amniotic fluid sample and it will always be contaminated. So the thing is, the amniotic fluid sample and it will always be contaminated. So the thing is, we have to go in by the clinical parameters. And these are mentioned over here also in this table. Now, next question. Should corticosteroids be offered if PPRM occurs more than 34 weeks? Everybody said 34, less than 34, more than 34. Kya funda hai?
Not in.
Yes, it can be given.
Dr. Ranjana? Yes.
Yes, it can be given even after 34 weeks of pregnancy.
Yes.
Especially when we are doing cesarean section, then for 38 weeks it should be given.
Yes, so the thing,
there is no harm in giving.
yes. So peri-viable age 23 say 34 tak. So we should always give. But if according to RCOG, they may be offered more than 34 weeks also, up to 36 plus 6 weeks after counseling the patient, because these steroids, it has been seen and studies have been done that long-term side effects on the babies. Some of the babies, there are the poor cognitive performances, all that. But the advantage is that the NICU admission and the RDS, they are slightly less. But otherwise, no difference has been found after 34 weeks. So they have to be offered after proper counseling. Now, what is the rescue dose of corticosteroids, Dr. Lata Gupta?
Rescue course of corticosteroids, they can be provided for the women with if more than 14 days have elapsed and gestational is less than 34 weeks, you can give 34-week one dose. One course of antenatal corticosteroids is recommended by the American Society. And if it is more than 34 weeks, it is questionable. This is doubtful.
Rescue therapy, yes, it has to be given if according to the RCOG, if more than 7 days have elapsed for the previous dose, then it has to be given. I mean, it can be offered. And of course, the delivery has to occur within 1 week of this second rescue dose. And only a single dose of steroid has to be given. And of course, not after 34 weeks. So 34 weeks, it has to be less than that. And the previous course has to be given at least 7 days before. So it should not be less than 7 days. And ACOG needs 14 days ka cut off there. So it can be more than 7 days or according to ACG, more than 14 days.
It says as early as 7 days for the prior dose.
Yeah, yes. Not beyond, not less than 7 days. It should not be less than. Now, what is the role of magnesium sulfate in this particular patient? 34 weeks ka hai, ye PPRM karke aaye. What is the role of magnesium sulfate? Should I give? Charu.
Yes, ma'am, because the patient is already 34 weeks, so ideally there is no role of magnesium sulfate in this patient.
No role. Yeah. So when is magnesium sulfate actually given?
It is ideally given between 28 to 32 weeks of gestation. It can be considered, but it is mainly given for neuroprotection, and it should be given within 24 hours of the imminent delivery, either induced or the patient is going in self.
Correct. So if you give it very, very early, it is of no use. It will be practically useless. So it has to be given within 24 hours delivery. And if elective cesarean section is planned, then 4 hours, at least 4 hours before the section, it has to be given. Now this patient, next slide. This patient had clear like a draining on examination. She was afebrile. Her blood counts were total leukocyte count 12,000. Uterus was around 35 weeks, relaxed, and the presentation was cephalic. The head was free. Ultrasound findings revealed that AFI was 7, gestational age was 34 weeks, and Doppler studies were normal. So, what is the plan now? This anyone can take the like it's not written. After Charu, who is there? Dr. Sangam? I don't know. Nobody like.
Ma'am, the recent RCOG guideline, it states that we don't need to induce. They can be allowed to progress.
Yes.
This is the latest. But yes, we need to monitor her closely. There is no indication because even if it is oligohydramnios at this stage, the Leica replenishes after 24 hours. So there is no indication for that to deliver.
All right. But this
very closely.
But you have to monitor.
Yeah.
Yes.
So you have to monitor.
NSTs, by CBCs, by high vaginal swabs, and daily fetal movement count also has to be done.
So Betnisol coverage has to be done, and after so in this case everything was done. NST was normal. Counseling was done for conservative management. Repeat counts after 48 hours was done. Daily, all this was done. And after 36 hours, patient went into spontaneous labor and delivered a 2 kg baby vaginally. So the case went well. Now next is Dr. Monica's last case.
Do we have time for the last case, ma'am? Dr. Supriya ma'am was saying we were out short of time, or we can go through this very quickly.
Supriya, it is not a big case, Monica. I think you can just rush it through.
So, So there's a Gravida 1, first Gravida. She is a diagnosed case of MCDA twin, and she has had an uneventful pregnancy till now, having a normal level 2 scan.
One thing, you should be very quick because we are
Yes,
running
ma'am.
late.
Yes, sir. Yes, ma'am.
Very
Sure,
quick.
ma'am. Yes, ma'am. So at 24 weeks of gestation, again, she complains of breathlessness and tightness of abdomen, sudden increase in abdominal girth. And in the USG, you can see the picture here. The twin A is having this amount of a single largest pocket, single deepest pocket, and twin B is having just this amount. So what can be the cause? What would you suspect? We'll just give one word answers and we'll try to complete this case in 5 minutes. So Dr. Shraddha, what would you suspect?
Because if this is a twin pregnancy with oligohydramnios in one pocket and polyhydramnios, most likely diagnosis will be twin to twin transfusion syndrome. Other will be TRAP and twin anemia and
Polycythemia syndrome. Okay, thank you. So we know that it is exclusive to monochorionic placentation, where there is a single placental sharing. There are vessels which are communicating, and it leads to imbalance in the perfusion of one of the donors and the recipient. So what can be the problems in TTS syndrome, Dr. Vinita? Just one or two?
There is anemia in the donor twin, and in the recipient twin, there is polycythemia, circulatory overload, hypervolemia leading to cardiac failure. And also, if the one twin dies, then the other twin suffers very badly, and there is neurodevelopmental issues in the other twin, irreversible damage to the survival
Yes, so
twin.
two things need to be seen. One is cardiac abnormalities, which can be present later also, and next is the neurological abnormalities which can occur in the twin. So how do we stage this? Do we need to stage? Because the severity will vary, so we need to have a staging system. And what is the staging system which is followed, Dr. Sangam?
It's a Quinterot staging system which is most commonly followed for the diagnosis and staging of the TTS. It is done by doing an ultrasound, where we need to demonstrate a polyhydramnios in one sac and the oligohydramnios in the other sac by using a deepest vertical pocket, not the AFI. And we look at the bladder of the fetus. In stage 2, there will be bladder will not be visible, and in the stage 3 there will be Doppler abnormality, and the stage 4 hydros will develop in one of the fetus, and 5 can be fetus in one or both the twins.
So with the increasing staging, the severity of the disease increases. So we should be prepared.
And the management will depend on the stage of the
stage. Yes. So severity is also staged, and the management totally depends on the stage of the condition that the patient is presenting. So how will we manage? What are the options? We'll just discuss the options. We will not go into the details of the treatment. So Ranjana ma'am, what are the options for management?
Frankly speaking, I refer this type of patient to higher center, such as Kurji Hospital or AIIMS Patna. So, but it should be done where fetal medicine center is available.
Are there.
That centrally. Fetal growth monitoring is done every 4 weekly, and there should be what is the MCV PCA, what is ductus venosus blood flow, that should be done every 2 weekly. And
that Dr. Sangam said that as for Quintero staging, we have to look for presence of bladders, MVP and MCA-PSV and the other abnormalities. And what are the options that are available? We just want to know the options. None of us are treating cases of TTS as of now because we are not fetal medicine trained. So these are the options we can discuss. What are the options, Lata ma'am, please?
We have the expectant management and amyloid reduction, interstitial septostomy of the intervening membrane, then fetoscopic laser photocoagulation of the placental anastomosis, and the selective reduction.
So for mild cases or the stage 1 cases, we usually go for expectant management. Amnio reductions only, as we have seen in other cases of polyhydramnios, where there is maternal distress, severe maternal distress. The most recommended method nowadays is fetoscopic laser photocoagulation of the anastomotic vessels on the placental surface. And sometimes we need to selectively reduce the baby, which is very sick, because that is going to cause death of the other twin also. So we need to reduce the baby, which is more sicker, to save the other baby. So these are the options that are available to us. Just to summarize, I'll just complete this slide that for stage 1, we need to do expectant management or laser ablation only if it is less than 26 weeks, and more than 26 weeks, usually expectant management or serial amnioreduction for severity of the symptoms. So we'll skip these slides and we'll come to the delivery plan. So Dr. Charu ma'am, when do you plan to deliver this lady?
Yeah, if everything goes all right, then we can prolong the pregnancy to 34 weeks, and ideally it should be delivered somewhere between 34 to 37 weeks.
Yes.
And plus, moreover, the timing of delivery will depend on so many factors like disease severity, as you rightly said, then progression. If any intervention is done, then what is the effect of that intervention on the baby? And ideally, the baby has to be taken out somewhere between 34 to 37 weeks.
36 weeks. Okay. Thank you, ma'am. So we go to the more important aspect. We are not concerned with the delivery, or we are not treating actually the cases. So do they have any long-term outcomes?
We need more studies for it. Like very few centers in India, they are doing it. Most of the studies are from UK and USA. But yes, we have found that 9% of these, because when we are using laser, we are using energy. So 9%, the studies, they have shown that 9% of these fetuses have neurodevelopmental abnormality.
Okay, thank you. So is screening important in TTTS? That is the only thing that we can do to prevent or to diagnose early, not prevent, but to diagnose early. So how can we screen, Dr. Vinita, for TTTS?
We start screening from 16 weeks and we
Very important,
screen
yes.
bi-weekly. Every 2 weeks
So for all
interval, we
for
screen, we
monochoria.
see the lichal volume in each of the amniotic sacs, and we see the Doppler studies we do. We also see the fetal bladders.
Yes, this is for especially for monochorionic twins. For dichorionic, the
monthly
screening is different, or the follow-up is different. This is only for the monochorionic twins. So with this, we end the last case, not going in much detail. So the take-home messages for this panel would be that a clinical assessment should also be a part of good antenatal care. We should be able to assess that the lichar is less or more clinically first, and then go on with the ultrasound. And because lichar abnormalities will affect the fetal growth and health, semi-quantitative measures like AFI and SDP both have their own utility in different cases. Isolated cases of oligohydramnios and polyhydramnios, meaning idiopathic ones, they definitely have better fetal prognosis. The aneuploidies, congenital anomalies, they need careful evaluation. In cases of amniotic fluid abnormality, sometimes they can be presenting later also. So multiple ultrasounds may be required. And MCDA twins have multiple complications, and TTTS should be carefully screened from 16 weeks. I wish to thank all my excellent panelists for participating so enthusiastically in this panel.
So big round of applause for moderator.
The moderators were excellent.
Charu, before you take.
Yes, sir.
So big round of applause for 2 learned moderators. They have nicely conducted panel. Yes. And at the same time, round of applause for all the panelists also. They have made panel very interesting and live. Very good.
And applause for the MC Patel sir also.
Thank you. Thank you, madam.
Thank you for giving our society to be a part of this program, sir. Thank you.
Yes, madam.
Sir, on behalf of all the panelists, we pay our sincere gratitude to you for giving us this wonderful opportunity. Thank you so much, sir.
Yes.
Welcome.
Thank you, sir.
So, Kalpana. Or Supriya. Or
Yes, sir.
So, formal vote of thanks.
Yes, sir. So, sir,
I wanted to know one thing.
Yes.
Are there any fetal medicine experts in Bihar in our part?
No.
In Patna.
For what? What expert?
No,
Fetal
fetal
medicine.
medicine. I'm asking
Fetal
the
medicine.
No, not in Bihar. It's an Amrita Institute, Kochi. Dr. Suresh sir from Chennai, and I think SGPGI is there.
Just started. In Savannah More, she's having a feature, but she's dealing with these cases.
But she's not doing this laser therapy and all.
No, laser therapy she's doing.
Amniocentesis
Sorry
and
to
PVS we
interrupt.
are also doing at AIIMS Patna. Amniocentesis and PVS, those procedures are only what she is performing right now. So
Sorry to interrupt.
advanced fetal therapy is not available anywhere. So we will be planning something.
Amrita Institute.
Not in, ma'am is asking about Bihar.
Sir, Madam Shanti Roy wants to say something. Madam, kindly unmute.
Welcome, madam.
Madam, please unmute.
Shanti ma'am, please unmute.
Madam, you have to unmute. Can't hear you.
Madam, unmute yourself.
Okay. So at the end, I will propose the vote of thanks. So it is a proud privilege for me to propose the vote of thanks on such a nice, happy learning class today. It was a wonderful program actually. The talk, everything was very nice. So first of all, I would like to thank the director, program director of this program, the man behind the show, Dr. MC Patel sir, for arranging this wonderful program, sir, Happy Learning. We were not very sure post the Dashara how it will be, but it came down so well.
Yes.
So thank you, sir. Thank you very much for this wonderful program. The chief guest, Professor Dr. Padma Shri Dr. Shanti Roy, madam, for being the chief guest and staying till the end, madam. Thank you so much. And also for your words of blessings that you said in the beginning. So thank you, madam. And the guest of honors, Dr. Manjuta Mishra, madam, and Dr. Pramila Modi, madam, both senior members, they really always, once they say yes, they are really committed, sir. They will come, because I had a talk with them. They said, definitely, मैंने तो बात किया हुआ है पटेल sir से, so we have to come. So they are always very much committed, and thank you, madam, for that. And then the conveners, Dr. Neeta Singh, madam, the president.
Issue.
I'm so sorry. Yeah. So, can you hear me now?
Yes, yes.
Some net issues.
Yes,
right?
yes.
And so the convener, Dr. Vinita Singh, President, POGS, she's always there. We had a talk, so we have to make this program. And Vinita, thank you so much. So you also were right from the beginning till now. And Dr. Sneha Bhuyar, she sent her apologies because she had to travel somewhere. And then the esteemed speakers of today, Dr. Rita Kumari Jha, madam, she was keen on making this topic very interesting. She read all the books and really she presented so well. Thank you, Rita Di. Dr. Rakhi Agarwal, she was always wonderful.
Welcome, Supriya. Thank you very much, Dr. Patel sir, Dr. Vinita Singh, and Supriya. Thank you very much for the opportunity.
Yeah, Dr. Rakhi Agarwal, she's also always very keen to come on this platform. Thank you so much. And Patel sir, Dr. MC Patel sir, your talk is always very good and very liked by all the gynecologists.
Thank you, ma'am. Thank you.
Thank you, sir. Thank you, because you talk on the legal
Always, always be like.
Everybody likes her, and we really mesmerize.
Supriya?
Yes.
Supriya?
Yes, madam. Yes, madam.
When I was told to join, I thought I will not be able to complete the whole session, but then I was not willing to get up and go away. I just finished everything and enjoyed quite a lot and learned so much. Sabse badi baat.
Yes.
Learned too much.
Thank you, madam.
All the panelists, the panel discussion was really great.
Yes.
All thanks to Dr. MC Patel and everyone for that matter, everyone who has taken part.
Thank you, ma'am. Thank you.
I also thank the chairpersons, Dr. Vinita Singh, madam, Dr. Kalyani Singh, madam, Dr. Lakshmi Sen, Dr. Pragya Mishra, Nibha Mohan, and myself. I thank the moderators of the panel discussion who really took
real interest, Dr. Jyoti Malhotra and Dr. Monica Anand, the two vibrant young moderators of this panel discussion today. Then the experts were Dr. Sneha and Dr. Rekha. So thank you, both of them. And the learned panelist, Dr. Ranjana Jha. I know, Ranjana, you are always interested in the panel. And Dr. Lata Gupta, Dr. Charu Modi, Dr. Shraddha Chakyar, Dr. Vinita Sinha, and Dr. Sangam Jha. It was a wonderful panel. And thank you, Corona Remedies, for this platform they have given, and Mr. Vashish, Dr. Vasu, and Abhishek. They are all so very cooperative, and they made such good slides and all the CVs they compiled. Thank you very much. Thank you, everyone, from core of my heart. Thank you.
Thank you.
Thank you so much, ma'am.
Thank you. Thank you, sir. Thank you, everyone.
Thank you. Thank you, everyone.
Thank you, everyone.
Yes, Abhishek, you
We'll
can.
love to
continue.
meet you again, sir.
Oh, yes. Welcome.
Thank you. Thank you very much, sir.
Okay, welcome.
Thank you, sir. Thank you. Good night, everyone.
Okay, good night.
Bye-bye.
Abhishek, you can conclude.
Yeah, Mr. Abhishek, he was very, he did. Thank you, Mr. Abhishek. He made it
Yes,
so.
thank you.